Three, two, one. Please start, sir. We are live.
Okay, okay. Namaste and good evening, everyone. I welcome you all for today's webinar on clinical update in GI and GU malignancy. With immense pleasure, I would like to invite Dr. Nitish Gar. He is Assistant Professor Medical Oncology at DNL Medical College and Hospital, Ludhiana, for the welcome and introductory note. It's over to you, sir.
Thank you, Nishant, for the introduction. This webinar, what we are planning to do today and tomorrow, will be based on clinical updates on a genitourinary and gastrointestinal malignancies. So it is going to include all the updates, small glitches, small discussions on what is happening in the hepatocellular carcinoma, what is happening in the biliary malignancies, and then the discussion on a colorectal malignancies. Because every day when we get up and look at our updates, we see ASCO has a new data. So if there is a new data every now and then, we have to keep ourselves updated. So definitely hepatocellular carcinoma, I would like to start with that first. And in hepatocellular carcinoma, there has been recent updates like need of adjuvant treatment, need of adjuvant immunotherapy, or a role of upfront transplant, or there has been some case reports where the discussion goes the treatment first, the reduction in the size, and then the surgery or a transplant. So my academic partners, all of them, I would like to welcome and thank them to be a part of this meeting. And I would like to invite my first speaker, who's my dear friend, Dr. Jagdeep sir. So he will be talking on recent updates on uh, resectable hepatocellular carcinoma. I believe sir is there, Dr. Jagdeep.
Yes, Nitish.
How are you, sir?
Fine. Looking fresh, man.
Thank you. Thank you.
Ready for the webinar.
Yes.
So
what do you, sir?
best wishes to you and congratulations for hosting this event.
Thank you.
So shall we start?
Yes, please go ahead.
Okay, thank you. So, is my screen visible?
Yes.
Yes, sir.
And can you tell that whether it is moving in presentation mode?
Yes, sir. Yes,
Okay.
sir. Moving.
Thank you so much. So, as today's webinar is focused on the G and GU malignancies, and as already Nitish mentioned, a lot of data are coming, and we have moved in case of SCC from immunotherapy plus bevacizumab combination in the unresectable metastatic setting to the adjuvant. So the first thing is, I think this is the first study which has given some sort of edge in patients with a resectable SCC in case of our relapse recurrence-free survival. Though the data for OS is still not mature, might be in that shortly we will be having that data. But of course, this is one line which was initially not there for the patient of the SCC. So we'll be going through that data and some of other things. So my assigned topic is what are the emerging therapies in the high risk early adjuvant SCC and how we manage these patients with the high risk SCC. So overview of this disease. So everybody knows this is a third leading cause of death worldwide. And approximately in 2021, it was estimated that in US, close to 42,000 patients are detected, and approximately more than 70 to 75% patient, they die of this disease. And this graph shows the incidence as well as the death rate has increased in the patient with the SCC. So you can see as the incidence rate has increased, of course, the death has, of course, that will be more in patient because number of patient detected more and therapies are little less. So that's why these are going hand in hand. This is the hepatocellular cancer disease burden. You see in 2023, close to 41 patients thousand were diagnosed with the SCC, and approximately 70% they died of this disease. And the most causative agent for SCC is the liver cirrhosis, irrespective of the cause. Could be alcoholic, could be viral, could be metabolic associated NASH, or could be autoimmune or other as disease which can lead to the cirrhosis. If we talk of the survival rates with the patient with the SCC, this remains pretty low in all the liver or biliary cancer. And if you see approximately the overall 5-year survival rate are close to 20 to 25%. And with metastatic disease is a very, very dismal figure, that is just 3.5%. In case of localized SCC, which is often asymptomatic, so that many patients with SCC are identified through screening. However, because of this underuse of the screening and other factors, up to 40% of the patients are diagnosed with the intermediate or advanced stage. So usually when the patient present to us in our clinics, we usually see in BCLC stage C, or maybe in the maximum, sometimes we only offer the best supportive care. So that's the most important thing which we want to point with the patient who present in the advanced stage, the dismal is very poor. So this child book score, which is a very important component in deciding a patient. So usually patient in the child book B from 7 to 8 or 9 maximum that are usually encountered in our day-to-day practice. C, we always give a chance of our best supportive care, and A usually very rarely seen in our OPD. So of course, there are a lot of other factors when we're deciding a treatment with the patients. So this varices, which is a very common with the patient with the decompensated cirrhosis, they can be one thing when we are planning a treatment with a based therapies, because if the patient have a active bleed, this is one of the contraindications, and we usually don't give those therapies. So this evaluation for the varices has to be there for the patient with the SCC. So another important tool is LB scoring. LB scoring is albumin bilirubin scoring, and it is again an important tool. Patient with the high LB score, they tend to do a poor as compared to the patient who have a low LB score. So based on this, there are 3 grades, grade 1, 2, and 3. And patient with a high LB score, they tend to do poor as compared to the patient with a low LB score. This is the most important classification in deciding a treatment for any patient of SCC, starting from stage 0 to stage D. So based on all the factors, single nodular, multinodular, or portal vein invasion, or extrahepatic disease. So we have to decide a treatment based on this. And very early or early stage are the patients who can have a cure in the form of either transplant or resection or ablation done in those patients. So surgical therapies have given outcome in the patient. If you see the patient who underwent a liver transplant or resection, who either have a even resection is based on patient whether have a high bilirubin or high portal hypertension. So these are the factors which decide whether the patient is fit for surgery or not sometimes. So you see the patient who gets a surgical treatment in the form of either liver transplant or resection, they have a good survival in those. So you can see in overall survival in the case of liver transplant at 4 years is close to 75%. So the patient who get a liver donor transplant done, they tend to do better, and is one of the best modalities if offered and if available. So these are some of the criteria like Milan criteria, DS criteria, and based on this, then we have to decide that which patient is a candidate for the liver transplant, or sometimes on the basis of this DS criteria, sometimes we have to decide specifically a patient can be offered a transplant or not based on this. This Milan criteria have historically defined liver transplant eligibility, and it was a reported outcome among the 48 patients using Milan criteria. And it showed a median follow-up after 26 months. In case of, you see, RFS is close to more than 80%. And patient with the same who get this transplant, overall survival at 26 months is close to 80%. So a good number of patients, and they tend to do better when they are offered a liver transplant. So again, this UNOS DS, that is a downstaging of this liver tumor, patient who have that outcomes, they tend to do better post-transplant. So this was a multicentric trial in which patients either who were fit for the Milan criteria or post who get a downstaging of a tumor and they fall within the Milan criteria, or who are there outside the Milan criteria. If you see the patient of Milan criteria, they tend to do better. But who get the downstage, they are even still better than those who are beyond Milan criteria. So in these graph, if you see 10-year overall survival and recurrence rates were close to 52 and 20% for the patient for downstaging versus 61.5% and 13.3% for the Milan criteria. And beyond Milan, if you see, it is the least number, that's 43.3% versus 41.1% in those patients. So benefits of the consolidation therapy with the transplant in this XXL trial. This is a phase 2/3 trial among the patients with the lower localized SCC beyond the Milan criteria. And the patient with response after downstaging therapy were randomized to receive either liver transplant or to a no transplant. And it has been seen the patient who underwent transplant, they have a better EFS or overall survival as compared to those patients who does not go for a transplant. So recurrent rates after transplant, if you see this shows that patient even after transplant still has a high recurrence rate, even if you achieve a good CRS. So still it needs, it shows that there is still unmet need for a perioperative therapy to reduce this recurrence rates. And we will be addressing this shortly. So based on the BCLC criteria, whether we are going for any localized therapy or transplant, or we are going for a systemic therapy, or in between for the BCLC-C due to vascular, can be a patient for a TACE, TARE or SBRT. So starting from the loco-regional therapy to the best supportive care based on the different modes of presentation of patient, we have to decide for the patient. And the systemic therapy may be preferred in a patient who are unsuitable for some of the loco-regional therapy like TACE. And it has been seen even that the patient who are not fit for TACE, who received some sort of systemic therapy, they tend to do better as compared to the patient who get a TACE. They are unsuitable for this, and still they tend to do better in those patients. So what are TACE unsuitable patients? How we define that TACE unsuitable defined? And this is by the Apple consensus conferences, and that is used by up to using 7 criteria. So based on the size and number of nodules, we take a criteria, and based on this, we say that patient is whether suitable for this TACE or not. So a multinodular may be more than 6 to 7 nodules. They usually have a poor response to the TACE. And again, the patient with a high size of this tumor that is more than 5 to 6 centimeter, they are also have a poor response to the TACE. So these patients are one of the subset of the patient which are better can do with the systemic therapy rather than going for a TACE, though it could be one of the options which can be offered. But still, one of the caveat is not a very widely accepted threshold. So usually people do not go with this. Another important thing in case of SCC is a multidisciplinary care. So involvement of the oncologist with the hepatobiliary surgeon, radiologist or pathologist along with the transplant. And it has been shown the patient who go for a multidisciplinary care, they have a better improvement survival in those sections. So multidisciplinary care is associated with the improved clinical outcomes in the patient with the hepatocellular carcinoma. And it has been shown in some of the systemic reviews and meta-analysis which have given that patients who have a multidisciplinary care approach, they tend to do better. Of course, the limitation is there, including a potential referral bias and the study heterogeneity, these are there. So now coming to what are the treatment which can be offered to the patient with a high risk early stage SCC, and how we define this high risk early stage. Of course, that is based on the tumor burden, based on the AFP level, and differentiation of the biopsy if the biopsy is done in those patients, and based on the nodules. So multinodular, of course, will have a high tumor burden, high AFP level, they are the high risk features. So a lot of research was there initially for the whether we have to give some sort of adjuvant therapy in patient who underwent a surgery or not, or some new agent. And in the STORM trial, which sorafenib is given as an adjuvant therapy, did not show any benefit as compared to the placebo. So based on the liver resection or section, adjuvant therapy guidelines are there. So AASLD states it recommends the use of autoimmune checkpoint inhibitor-based systemic therapy in a patient with a high risk, which we'll be just discussing. That is IMBRAVE 050 trial. And ESL in guidelines in 2018, they does not mention any recommendation of the adjuvant therapy because they have not been proven at that time. And NCCN at present, no adjuvant therapy because this trial has given this IMBRAVE 050, this interim result is out, but still the longer follow-ups are needed for those results to incorporate whether this adjuvant therapy has to be there in not. That's why it's not still included in the NCCN. So other thing is perioperative strategies are being used in SCC, like whether we downsize the tumor and they have a better outcome as compared to the patient who does not fit into the beyond the Milan criteria. So still no randomized data is there as compared to the upfront surgery. So there are now therapies which are used as new adjuvant and some downstaging which give a overall response rate close to 30 to 35%. And it is anticipated that it might reduce the micrometastasis. And important adjuvant therapy is the IMBRAVE 050 trial results are available for the RFS, but OS results are still not available. Other ongoing phase 3 studies, which includes this aramlad, that's durvalumab plus bevacizumab, and pembrolizumab, and checkmate 9DX is a nivolumab. So we don't have the results of till now, but IMBRAVE 050 is out with us. So efficacy of this immune checkpoint-based therapy in advanced SCC. So this trial, we very well know that is an unresectable or metastatic IMBRAVE 150 trial, which has shown that the combination of atezolizumab versus plus bevacizumab versus sorafenib first line, and it has shown that patients who tend to receive this combination, you can see in 6 months, 12 months, and 18 months, median survival, overall survival was better than the patient who are receiving the sorafenib. So median PFS was 6.9 months versus 4.3 months in the sorafenib, and the overall response rate was close to 30% with this immunotherapy plus bevacizumab combination as compared to sorafenib, which was 11%. So another trial, Himalaya, which was a durvalumab plus tremelimumab versus sorafenib, again for the first line was SCC, and it has shown the patient who received this durvalumab plus tremelimumab, the median overall survival was 16.4 months versus 13.7 months with the sorafenib. So still difference of there, but you can see that they have shown that statistically significant, but honestly, there is no such experience from my end using of this durva plus tremelimumab, and it has been shown to be overall survival to be superior to the sorafenib, and durvalumab monotherapy overall survival was non-inferior to the sorafenib. So if you see the overall response rate, that is close to 20% in the combination versus 17% with the durvalumab single agent as compared to 5% with the patient who received sorafenib. So in patient with the durvalumab plus tremelimumab, the overall survival is better as compared to the sorafenib, and monotherapy still tend to do a better even in those patients as compared to the sorafenib. So this adjuvant atezolizumab plus bevacizumab versus surveillance for the SCC patients who underwent resection or ablation. This is a phase 3 open label randomized trial, IMBRAVE 050. And of course, the patient who had a resection or ablation within 4 to 12 weeks without any evidence of a macrovascular lesion or extrahepatic disease with a high risk feature of SCC, they were randomized either to surveillance or to the combination of atezolizumab plus bevacizumab every 3 weekly. And it was given for a 1 year. And the primary endpoint was the relapse-free, recurrence-free survival, with the secondary endpoints OS and RFS by the PDL1 status and time to recurrence and the safety. So this was the criteria for the high risk, that patient who had the SCC recurrence by curative treatment. If you take into account of a resection, that tumor less than 3 in number or largest more than 5 centimeters, irrespective of the vascular division or the differentiation. And if the tumor number is more than equal to 4, with the largest less than equal to 5 centimeters, again, irrespective of the vascular division or the tumor differentiation. But if the number of tumor size is less than 3, equal to 3, or largest is also less than equal to 5 centimeters with vascularization, they could be offered the resection. But in case of the ablation, which was given in those subset, it's a single tumor more than 2 centimeter, less than 5, and multiple tumors less than 4 in number or equal to 4 in or less than equal to 5 centimeter in size. So based on this criteria, patient was either offered a resection or ablation, and followed they were given an adjuvant therapy with the atezolizumab plus bevacizumab for at least 1 year. So baseline characteristics were well balanced in both groups, in both surveillance as well as the combination. And again, the curative procedure which was offered, it was again balanced in both sides. Approximately close to 88% or 87% of the surveillance, they underwent a resection as of against 12% or 13% of ablation in both groups. So if you see the safety analysis in the patient, the EMBRACE study, so grade 3 or 4 benefit, grade 3 or 4 adverse events were seen more in the patient who received this combination of atezolizumab plus bevacizumab as compared to surveillance. So efficacy of this EMBRACE 050, if you see the patients who received this combination post ablation or section, so 12-month independent review, this RFS event was approximately 78% in the combination as compared to 65%. So disease-free recurrence was approximately in those patients who received this 12-month event-free was approximately 20% in the combination as compared to the 34%. So disease recurrence in the patient who received this combination, so in the independent review assessment, it was shown that patient who received this combination was less as compared to the patient who were on active surveillance. So initially there was some difference in the, you can see some separation of the curves, but ultimately, so close down the line, approximately 18 to 20 months, the curves merge with each other. So though it has shown some benefit in the RFS, but it's not still, the OS data is still not mature for this. So maybe if there is some longer follow-up, the curves, if separate, then we tend to know, or if it does not happen, then it might not be a standard of care in the future. So another adjuvant is durvalumab plus bevacizumab, or durvalumab alone, or placebo. So this was again in the high-risk patient of SCC, again a phase 3 trial, and primary endpoint was the RFS of patient for the durvalumab versus placebo. So other ongoing adjuvant trials were for the keynote 937, in which the pembrolizumab was given in the patient as compared to the placebo, and the primary endpoint was again RFS and OS. And other drugs were nivolumab versus placebo, and pre-op tremelimumab plus durvalumab followed by the adjuvant durvalumab. So these trials are going on, and result has yet to be out. So, another trial is Emerald-1 in case of unresectable SCC. The patient were randomized into 3 groups. Arm A was durvalumab plus TACE. Arm B was durvalumab plus TACE followed by durvalumab plus bevacizumab maintenance. Arm A was only durvalumab maintenance, and Arm C, in which there was only TACE followed by placebo. Again, the primary endpoint was the PFS for Arm B versus Arm C. That is a patient who receive a combination of durvalumab plus bev maintenance as compared to the placebo. So it has been seen the patient who received durva plus bevacizumab combination, the median PFS was 15 months in that versus 8.2 months in the placebo, followed by with placebo, which was followed by TACE. So 12-month PFS rate was approximately 55.5% in the durva plus bevacizumab combination as compared to 39% patient who was on the placebo. With the patient who received durvalumab plus TACE as compared to the placebo plus TACE, if you see the median PFS is 10 months in the durva plus TACE, followed by the durvalumab maintenance as compared to the placebo, which was given followed by the TACE. TACE was given initially followed by placebo. So this was not statistically significant, though there is some difference in the PFS, but it was not significant in that. So this is
request to you, please continue
sure.
in next
So
minutes.
again, the response rates were quite similar. Either you give durva or TACE, or as a durva plus bev or TACE combination as compared to the placebo. So there is a rationale for neoadjuvant immunotherapy also, because to use as a primary tumor as source, we need to tend whether how the tumor biology behaves. And if we tend to reduce the tumor burden, we might achieve a resection. So these are the trial for Nivo plus Ipi and Samilipib for the resectable SCC. And again, combination of cabozantinib plus nivolumab in the locally advanced or borderline resectable SCC. So to summarize, surgical resection is offer the best long-term survival, but of course limited by the high recurrence rate. And adjuvant therapy using TKI failed to prove a benefit. There is some data with the immunotherapies in the neoadjuvant settings, which have led to the several phase 3 studies which are going on. And recent data suggests that the safety of immunotherapy in a pre-transplant setting, but there is a high risk of graft rejection when administered in patient post-liver transplant. And of course, the multidisciplinary care of patient with SCC critical and has been shown to significantly improve the overall survival. Thank you so much.
Thank you, Dr. Jagdeep, for that extensive update on the newer
Good evening, Kunal
things
sir.
which are happening in the hepatocellular carcinoma area. So I would like to add that there has been a few updates based on the TKIs, like hepatocellular carcinoma, where we do a taste. Adding lenvatinib has shown a better response. And there is a recent most data where the patient after a resection had a reoccurrence, undergoes TACE, that is a LANCE study, and we add the lenvatinib, the responses have been good. So the 1 year DFS when we add lenvatinib to TACE has a delta of approximately 18 to 20%. And as of now, the DFS is interim. The whole of the data is not out yet. So definitely immunotherapy, we actually should find out which are those high risk patients where we will have the benefit. So
like
looking
data
at
for TACE followed by lenvatinib. So can we say that we can give lenvatinib post TARE also?
So
There is no data still that
extrapolating
TARE
the
followed by
data
lenvatinib.
may be right also, sir, because the one local therapy they have tested, they might not be able to test another local therapy. So that way, and also the availability of TARE and most of the places will be difficult. TACE has now still become slightly more common.
The thing is that actually
Definitely.
I told one patient TACE plus lenvatinib. He asked me that if I go for TARE, somebody has given me option of lenvatinib. I honestly said that I'm not aware, but there is no such data. But yes, one loco-regional therapy you are combining, might be you can extrapolate from that combination of another TKI with the
Yes.
loco-regional therapy can be then one option. Kunal sir,
Yes.
you can give some insight. You are thinking so much. You are from the Roche panel.
Yeah, but I'm not the one who gets the patients who are eligible for TARE. Our patients are only for lenvatinib.
I think, sir, we should ask Dr. Yuganshu and Dr. Borhan also, who are also there. What are their opinion on this? The recent updates, Lenva adding or immunotherapy, though post resection we don't have. Dr. Borhan and Dr. Yuganshu, what are your views? Then we'll go ahead with the next section.
Thank you.
Yeah, I think although I have joined a little bit late now, I think we have a next session. But in the times to come, I think we have new exciting data that is coming up from the trials. I think that will throw some more lights about on this topic. But personally, I have not actually, I don't know the context which we were talking about because I have joined late.
It
So
was
Kunal,
basically
like whether we can compare, we can combine lenvatinib post TARE or not, like we give TACE
or local like
TKI.
Yeah. So what the data actually I have remembered for the sorafenib, it did not show much of a benefit. There was a study where sorafenib had not shown much of a benefit advantage after the TARE. But for lenvatinib, I have not used, and I maybe the literature may be there, but I have not used in that context.
Kunal sir,
so I think
your update was still missing.
Yeah.
Sir, you are muted.
Jagdeep?
Yes. Buran, I thought that we can extrapolate that if TACE can be compared with the lambda, TARE can be, but there is no data for still there.
Yeah, I
Yeah,
would
I think
agree. I
that's
think
what I'm
lack
saying.
of data may not mean that you cannot give. If the patient is fit and has a good liver function post the procedure, you can still give tear, but again with the rider that there is no phase 3 data, and to collect so many patients with post tear will be very, very difficult. I think to have that kind of patients number to show that benefit that was shown in the launch study with the lenvatinib will not be possible, I think.
Right. So thank you, Dr. Chandeep. So now we'll move to our next session, which is sponsored by Roche. So I'll call upon Dr. Kunal Jain, who is Associate Professor and Head at Denon Medical College, Ludhiana. So sir will be talking about role of Tecentriq in the first line unresectable HCC. And we can keep the discussion happening in our next panel discussion. Please, over to you.
So, good evening, everyone, and thank you, Dr. Nitish, for inviting me to be part of this academic feast. And Jagdeep has already done, I think, in one slide that he had shown, he has already done my presentation, which he showed the benefit of this combination in the setting of advanced HCC, which can be either metastatic, unresectable, disease. That is what we commonly see in our day-to-day OPD. So some of the data he has already shown. I'll just go through quickly. So the global incidence of liver cancers, it contributes about 5% of all cancer diagnosis and is sixth most common cancer overall. And among the mortality, third leading cause of cancer-related mortality globally. And absolute numbers reaching close to 1 million overall global incidence of liver cancer. And it is 3 times more common in men. And there is a geographical distribution and variation as well. Majority of the patients, it is more common disease in kind of developing or underdeveloped countries rather than in the developed nations. And we see that Southeast Asia, Eastern Asia has a much higher incidence, whereas the developed world, it is almost maybe 8 to 10 times less than what we see in the Asian population. And among all liver cancers, HCC is the most common. There are other uncommon histologies as well. And the most common significant factor which leads to development of HCC is underlying cirrhosis, which is present in almost 90% of cases that we see. But we have to remember that about 10 to 20% of HCCs may arise without the setting of cirrhosis. And there are various causes for cirrhosis that we all know, majority being viral related cirrhosis, HBV and HCV. And then non-viral etiologies like alcohol, NASH, which has now been, terminology has been changed, and other aflatoxins. So ultimately, cirrhosis can lead to development of, there may be dysplastic nodules, which can ultimately turn into malignancy and may lead to advanced HCC. As per the Indian scenario, about 35,000 new cases of liver cancer as per the WHO data from 2020. And among the mortality, it ranks about 8th in terms of cancer-related mortality, close to 34,000 patients dying annually, and that is 2020 data. And 5-year prevalence rate being 2.8% means that the patients do not do very well and do not live very long. And that is the huge unmet need. The problem that we face is that majority of our patients are detected in advanced stages, usually, majority being with poor performance status as well, and also poor liver function, which prohibits major treatment options. And current options right now that we have at our disposal are oral TKIs, which give on an average a median overall survival close to an year. And if we see the reflect data, maybe about 14 months, you can say. But that was the best that we had until we had the combination of Atezo and Bev, Tecentriq and Avastin, which gives a similar or slightly better safety profile, but also led to a better overall survival. So during my training period, sorafenib had just been launched, and that was the only drug that was available, and also with a modest survival benefit. If you see the sharp data, the survival, median survival is close to about 10 and a half months. So that was the best option at our disposal at that time. And for 10 years, nothing happened. And then in 2017, we started getting various treatment options in this group. The first being lenvatinib, which was kind of a non-inferiority study, and then immunotherapy combination and single agents. The main being Atezo and Bev, which is kind of now the standard of care first line option for advanced HCC. Then there are other second line options, which we will just maybe allude to if we have time at the end. So why do we combine these two options? We know that this is a kind of a VEGF-driven tumor, and that is why the oral TKIs, which have mainly anti-VEGF properties, are beneficial in this type of tumor. So there is release of cancer antigens, which lead to cancer antigen presentation at from dendritic cell, which ultimately activates T cell, and these T cells are what can basically reach back into the tumor and attack the tumor cells and lead to the cell death. But cancer cells evade this presentation or attack by T cells because of expression of various receptors, and PDA1, PDL1 being some of them. So both these drugs, Bev and Atezo, have shown some synergy. Bevacizumab is an anti-angiogenic monoclonal antibody, and it has additional immunomodulatory effects. And in combination, Bev may enhance the efficacy of atezolizumab, which is an anti-PDL1 antibody, by reversing VEGF-mediated immunosuppression to promote anti-cancer T cell activity. So this is how, in the initial phase studies, this combination was developed, and ultimately led to the phase 3 study of IMbrave 150, where patients with locally advanced or metastatic and or unresectable HCC and no prior systemic therapy were randomized 2:1 to either Atezo in the standard dose of 1200 milligram plus Bev 15 milligram per kg every 3 weeks, or to the standard of care at that time, which was sorafenib, with a standard dose of 400 milligram twice daily. So treatment was continued until loss of benefit, and there were various stratification factors. And important thing to note here is that patients with macrovascular invasion or extrahepatic spread, which is the metastatic disease, were also included, and they were good number of patients in that in the study. And co-primary endpoints for overall survival and PFS, which were studied. Baseline characteristics were well matched. We can see the majority of the patients were males, as I initially mentioned as well. And the patients with the BCLCC were 80%, and the majority, so almost 70%, were related to viral etiology, and non-viral etiology were about 30%. And a good proportion of patients had extrahepatic spread, and almost 1/3 to 40% had macrovascular invasion. And if you see patients having either of these, almost 3/4 of patients, which are considered poor risk factors. So if we see the progression-free survival, which was one of the co-primary endpoints, there was an improvement by about 2.5 months, from 4.3 in sorafenib to 6.8 months, with a hazard ratio of 0.59, meaning about 41% relative reduction in risk of progression if the patients were getting atezo and bev at 6 months mark. And maybe I'll come to the systemic therapies later. So the overall survival, which was the other pro-primary endpoint, and that is what we are mainly interested in. At 6 months, there was a difference of about 7%, absolute difference of 7%. But that may be meaningless if we are seeing that benefit lose over time. But what this study showed that there was a almost 6 to 7 months improvement in overall survival when patients were given atezo plus bev combination. The overall survival was about 19 months, and in sorafenib it was about 13 months. So patients were living, 50% of patients living more than 1.5 years. So coming to the second, the other point, what were the subsequent treatment therapies that were patients were given? In sorafenib balm, almost 1/4 of patients did get immunotherapy. So whereas 1/3 of patients in atezo-bev did get subsequent TKI as well. So that may be important to analyze what happened in terms of overall survival, whether they were given standard of care or not. So patients, if you see the forest plot, not completely visualized here, sorry for that, but what basically it showed that the majority of the benefit was seen, the combination arm did show benefit in all subgroups, but some subgroups did show higher benefit, which was the viral etiology as compared to the non-viral etiology patients, and they showed better outcome. And if we see the overall response rates, there were near doubling of overall response rates to about 27% in the combination arm as compared to 12% in the sorafenib arm, and even complete response rates, which would be a rarity in HCC, were seen in about 6%, 6 to 7, and updated analysis, in fact, showed 7% of patients showed complete response. So similar findings. And when we consider a new treatment, we are always concerned about the safety level as well, and in addition to the cost. Safety-wise, this combination arm, serious adverse events grade 3 or 4 were seen in similar percentage of patients. We know sorafenib is not an easy drug for patients to handle, especially in the doses recommended, which is 400 milligram BD. Almost half of the patients will have grade 3 or 4 adverse events in both the treatment groups. But in atezo-bev, the majority of the problems were related to the usual bevacizumab was the culprit in terms of hypertension, proteinuria, and some patients with transaminitis. And adverse events leading to withdrawal of any component, which is also important, almost 16% in the combination arm versus 10% in sorafenib. And there was dose interruption in almost 50% of patients in the combination and 41% in sorafenib. Dose reduction was not allowed in atezo-bev. Obviously, for immuno, we usually do not do dose reduction, but for bev, also the same dose was continued. And this is again showing the kind of side effects that the patients will have. Usual problems with the sorafenib, like hand-foot reaction, diarrhea, decreased appetite, and most of the problems, as I said earlier, with atezo-bev, mainly related to bev in terms of hypertension and also proteinuria. And obviously, because of addition of immunotherapy agent, immune-related adverse effects as well, which is about 10% of patients, which may lead to serious problems. What we are also worried about when we are giving bevacizumab in any case is bleeding tendency. And what this study showed that overall rates of bleeding events did not increase significantly. Obviously, we have to be careful about varices, and one of the prerequisites for starting patients on bevacizumab is that they should have an upper GI endoscopy, and no significant varices should be there. And if they are there, they should be treated before we consider them for treatment with this combination. And hepatitis was also similar. What this means is basically hepatitis means derangement in liver function or transaminitis. Now coming to the patient-reported outcomes, which is the quality of life, their functioning physical or role assessment, and the other symptoms. So this study showed that the time to deterioration in the combination arm was much longer as compared to sorafenib, which is also because of better disease control and also related to the lesser side effects that you will see in terms of diarrhea, hand-foot skin reaction, which will also lead to symptomatic deterioration. So both the other factors, the physical functioning and role functioning, were also showed that there was a significant delay in the deterioration of symptoms when the patients were given atezo and bev. And now most of the drugs which have to be approved by FDA need to show improvement in quality of life as well, especially in the palliative setting. So this forest plot is again showing that the combination was better in terms of various symptoms that were reported by patients. What we give to our patients in first line is if they are eligible, affording, then atezo and bevacizumab in this category, or either of the two TKI, sorafenib or lenvatinib. I must say lenvatinib is more commonly prescribed now than sorafenib because of possibly better tolerance. And in second line, we have data only for ramucirumab if AFP is more than 400, or other TKIs like cabozantinib or regorafenib. And second line immuno, we do not have very robust data in terms of usage of nivolumab. Anyway, the approval was withdrawn, and pembrolizumab still can be considered for some patients. I'll not go into too much details about these charts, subsequent 3-4 slides, because we all know NCCN guidelines do endorse use of this combination if we are considering patients with advanced disease. But obviously, like Dr. Jagdeep was pointing out, if there are patients who are eligible for loco-regional therapy, I think they should be definitely given that option. In our setup, I think patients who are candidates for surgery or for transplant are quite uncommon. Majority of them do stay with, I think, the gastroenterologist till that time. And ASCO guidelines also endorse use of this combination. And of course, other option is sorafenib, lenvatinib. And similar is the case with the ESMO guidelines, which do consider this as a category A recommendation. So in conclusion, combination of atezo and bev has demonstrated efficacy in patients with unresectable HCC in this study IMbrave 150, and it demonstrated a statistically significant and meaningful improvement in OS and PFS. So the benchmark now is about 19 months OS benefit, which was not beaten by everyone. Was very hopeful from the LEAP 002 study that pembrolizumab and lenvatinib will possibly come out a winner, but the overall survival in that study was also kind of similar in terms of 19 months. And it was not because the control arm also showed the similar benefit, so it was a kind of a negative study. So this combination resulted in a clinically meaningful delay in deterioration of patient-related quality of life, which is very important, and other key symptoms. And this data highlights the benefit of targeting multiple steps in cancer immunity cycle and has potential to transform the current treatment paradigm for first-line unresectable HCC. Just ending by saying that there is another combination which already Dr. Jagdeep showed, the Himalaya study, durvalumab, tremelimumab, but numerically, although cross-trial comparisons are not good, but the magnitude of benefit was not that much. But that is still approved therapy for patients in this category. And we treat most of our patients based on the clinical or radiological findings. And that was true for this study also. 1/3 of patients were enrolled based purely on the clinical scenario, but 65% of patients did have some cytological or histological evidence based on FNAC or biopsy, based on which PDL1 testing was also done by SP263, which was retrospectively analyzed, and not much difference was seen, although there was slight difference in PFS in patients who had PDL1 positivity. But as compared to other tumors, the PDL1 positivity in this is relatively low, about 10 to 20%. and it will depend on how it is reported or how it is scored. So with that, I will end, and hopefully there will be no questions.
Thank you, sir, for that overview and excellent talk on Tecentric helping in unresectable HCC. So I think we can discuss our questions in the panel discussion. And I would like to invite Dr. Sandeep Kukkad. Sir is the Director Medical Oncology at Sohana Multi-Speciality Hospital, Mohali, for the panel discussion. So the panel discussion will be it will be a MDT approach on management of HCC, resectable or advanced. Over to you, Dr. Sandeep, sir.
Good evening, everyone,
You
and
can
thank
invite
you
your
very much
panelists, please.
for inviting me here today evening. So I think the text has already been discussed. We'll have a case-based approach, and let me just invite my lists for tonight. Can somebody share the screen on my behalf?
Yes, sir.
So we'll discuss something practical about how to approach a case of CC and what are the indications and contraindications while using the different approaches and different drugs. So let me first of all invite Dr. Deepak Bharti, who is from Shri Mata Vaishno Devi Narayana Super Speciality Hospital, Katra. Dr. Deepak Sinha, dear colleague from Indus Hospital. Dr. Burhan Wani, who's from AY Jalandhar. Dr. Ganshu Gupta, who's from MMU Hospital from Patiala. So I hope everybody is there.
Yeah. Good evening, sir.
Good evening, Doctor. So can everybody, Yuganshu is there, Dr. Burhan is there, Dr. Deepak is there, and Dr. Deepak Bharti is there. I think good to go. So let me go to the first slide. Can somebody give me the controls for changing the slides? Next slide, please. So it is about, next slide, please. So it is about how we manage applications of hepatocellular carcinomas in
Sir, we give control to you. You can change.
Thank you. Thank you so much. The slides are not moving. Control is with. Yeah, now they are moving. How important is to collaborate with other different specialties while managing unresectable HCCs? We all know that it is a multidisciplinary approach and we need different departments starting from the diagnostic part to gastroenterology to various interventional radiologists and coming on to the medical oncology part. Slides are not moving, Nishant.
Okay, sir. I'll move.
So this is a case of Mr. Subhash Tiwari, who's a 62-year-old gentleman with a history of hypertension, diabetes, hypercholesterolemia, coronary heart disease, and alcohol-related liver cirrhosis for 5 years. He was diagnosed as hepatocellular carcinoma in January of 2021 with a 6 centimeter mass in segment 8 on triphasic CT scan. So what next? Anybody can start. Dr. Deepak, you can start. What next? How many patients do you see? Those who are unresectable in a month, in a year? What is your definition of unresectable HCC? And how do you approach this patient?
So, good evening, everyone. Sir, I'm audible. Dr. Deepak.
Yeah, Dr. Deepak Bharti, please go ahead.
Okay. So, good evening, everyone. So, there are 2-3 things regarding that. As we know that if you ask me, out of 90% patients are unresectable, what we say in our routine practice, almost 90%. And only 1-2% patients are there which can go for liver transplant or some kind of rejection is there. But regarding unresectable, we are saying that anything which is multifocal, which is infiltrating the liver or has some portal vein thrombosis or some extra fatty spread is there with some ascites other way around or lung metastasis or nodal metastasis, which all are the criteria which can lead to the unresectability criteria. And number two, 90% are unresectable in our routine OPD practice. And this is obviously after that we have to take a multidisciplinary approach. as whenever we see the patient, obviously we have to take opinion of interventional radiology in any point of time, whether we can go for TACE or TR in such type of patients, whether it's indicated or not in our patients. And we need gastroenterologist for management of liver cirrhosis, or some endoscopy for if we want to add any VEGF inhibitor for variceal bleed or other way around. And if you ask, we need interventional radiology, gastroenterology, and obviously ourselves we need to manage the patient.
So Dr. Burhan, any comments to add on to what Dr. Deepak said? What is your
Yeah, I
definition of an unresectable HCC and how you approach this patient, what I described just now?
Yeah, good evening, Dr. Sandeep. So I think Dr. Deepak has covered those points. So a couple of things, that is that majority of the times patient once comes to the medical oncologist, most of the times it is an unresectable patient because it has been seen by a gastroenterologist many a times or by a surgeon. So coming to I think the criteria for the most of us are using the BCLS staging criteria for defining the unresectability. And as it has been pointed out that if there is a multifocal disease and or there is involvement of a major vessel invasion or portal vein thrombosis, that actually qualifies for a unresectable disease. And that is what we see majority of these patients.
So how to take it forward now? How do you approach such patients?
So once we use these patients, the important is that you have to do the diagnosis. Most of the time, the diagnosis is based on the triple phase CT along with the tumor markers that we take. And very rarely we are going for a biopsy in these patients. And the biopsy is done in some context where there is no underlying cirrhosis or the radiology is not very much suggestive, or you have a normal tumor markers. And in those cases, you go for a biopsy of the lesions. So otherwise, it's based on the radiology and the tumor markers. And if there is an unresectable disease, the important is that we go for the loco-regional therapies. That is the approach in majority of these patients.
Okay. Dr. Mubin, your comments on this case? I think
Then we have to decide whether it's a resectable disease or unresectable disease. One criteria is there. One is the Milan criteria, that is in which that if a single lesion of more than 5 centimeter or 3 lesion and a disease.
Just to interrupt. Nishant, the slides are not moving. Slides are not moving at all.
Control is not working. I will control. Please say to me next.
Okay. So yes, sorry, Dr. Mubin, please go forward.
Sir, one criteria is there, that is Milan criteria, according to which if the single lesion is less than 5 centimeter and if there are 3 lesions that are total disease volume is less than 9 centimeter, then patient can undergo resection or liver conservation therapy. And if the patient bilirubin is normal and if the bilirubin is raised and portal hypertension is there, and as Dr. Burhan said, these criteria are there, performance status is poor, multiple comorbidities are there, that patient is unfit for unresectable disease. As in this case, multiple comorbidities are there and the patient will not go for, according to me, for resection.
Okay. So provided patient is not having any underlying comorbidities, you would like to consider this patient for resection?
No. That is according to Milan criteria. If a single lesion less than 5 centimeter, then only can a patient be undergo for resection. Otherwise, we have to consult with the gastrosurgeon. And opinion is also.
So, any comments from other panelists, Dr. Deepak Singla?
Yeah,
Is 5 centimeter an absolute contraindication to go ahead with surgery if you have a single lesion, single solitary lesion, centimeter as presented in the case?
Actually, this patient is having another lesion in the segment 8 as well.
We are talking about a single lesion who's having.
Yeah, I mean, it's not a contraindication. If the performance status A and patient is fitting in the child A and BCLC, I mean, if for Barcelona Clinic for liver cancer, if it is patient is fitting into 0 to 1 stage, that patient can undergo liver section, a curative liver section, provided there is no major vessel involvement is there.
Right. So
5
I think,
centimeter is not a contraindication to, for liver resection.
okay,
Solitary lesion.
okay. So Dr. Burhan, any comments on the resection versus using an interventional radiology-based approach?
So in case of resectable lesions or
In case of such a patient where triphasic CT is showing two lesions, one is a 5 centimeter odd lesion in segment 5 and another lesion of 2 centimeter in segment 8.
I think in this case, what the actually, if we see the guidelines and the most of the times what we approach is the loco-regional therapies in the form of radioembolization, sort of embolization therapies, either a tear or a tear. That is actually most of the times taken into that is the approach for these patients.
Sir, sir, I
Can
want
this
to,
patient, can
sir,
this
I want
patient,
to add one point.
can this patient be taken for transplant or a resection based approach? Sir, we are having two lesions. One is 5 centimeter, other is a 2 centimeter lesion. Patient is well preserved, no hyperbilirubinemia, liver functions are normal. Apart from the comorbid status, I think he very well classifies into a good surgical candidate. So what are your takes on taking a surgical approach in such a patient?
So, if we, as far as the surgical indications of doing the transplant is concerned, I think some of the has been mentioned about the importantly the criteria that we have to fix, like the Milan criteria that we have to take into consideration. But importantly, as you said, the transplant, I think depending upon the center to center, many patients, some centers are taking it as a sort of a bridge transplant and getting the disease burden down and then taking them for a transplant rather than upfront taking them these patients for the transplant.
Dr. Yuganshu, your comments on taking
Dr.
this
Sandeep,
for
This is the
transplant?
same, Dr. Burhan. I would like to go first for a local regional therapy, and after that can think about transplant if disease responds to the same.
Why not upfront transplant?
Upfront transplant these lesions are not following the Milan criteria. There are two lesions. If one lesion would have been a 5 centimeter size, I would have gone for upfront transplant. Or the lesions, three lesions would have been all less than 3 centimeter.
So
I would
it
have
is
gone
just to take the input from from ourselves that what are the criteria that we are following nowadays. That is a single lesion, it is of 5 centimeter, three different lesions of 3 centimeter each, where you can resect it and there should be no angio invasion. So I think these are the criteria that we usually follow and all of us are following the same. So this patient fits into a Child-Pugh B7, BCLC B. Next, Yuganshu. Dr. Yuganshu, please take it
Dr.
forward. Next slide,
Dr.
please.
Sandeep, I want to add one point. Dr. Sandeep,
Yeah,
can I?
please go ahead.
Okay. So basically, we have found one point, but it's LFR, that liver reserve volume. Obviously,
Right.
whenever we are deciding the rejection versus this thing, we have to assess liver reserve volume. If it is more
Right.
than 30%, then we can go for resection also with these patients also. Okay.
Right. So I think liver volumetry is very, very important in deciding the criteria for resection versus a transplant. So resection, once you are considering, the patient should have a good liver reserve as pointed by Dr.
Because patient's background CLD patient is there. That's why.
Right.
Otherwise, if protein.
Exactly. Everybody agrees to it. Next slide, please. So surgery versus ablation versus TACE versus TARE, we have different approaches. Dr. Yuganshu, please take it forward. What would be your approach while deciding the treatment?
Sir, based on my experience, I will go for plus ablation.
So your voice is not audible.
Sir, based on my experience, I will go for TACE plus ablation. TACE followed by ablation, local ablation.
Right. Dr. Deepak, your comments.
Yes. I will go for local regional therapy. TACE will be my choice.
Okay.
TACE. Only TACE.
Anything to add on to TACE? Next slide, please.
We can add.
Yeah, please, Dr. Deepak, go ahead.
Okay. So basically, TACE and TARE both are options are correct in this case. It's all about the financial other way around. But in our routine practice, we are going for TACE only because it's a multifocal disease, and followed by after giving break, whether patient needs one session or two sessions. After that, we can add some sort of TKI as with a JS.
What are the candidates where you are preferring tear over TACE?
Basically, they are just like the multifocal disease. For these patients, we are for TACE only. For single lesions, we are going for tear only. And if someone has a portal vein thrombosis, in these patients, we are going for tear, not TACE, as it's a contraindication. And these are certain factors. And if someone has size more than 5 centimeters, we are not choosing TACE on that patients.
Right. So, Dr. Burhan, your comments?
I think the important is one is the availability of using a particular technique that is locally available. Secondly, is about the risk of side effects which we have
Majority of
seen
the
with the
times, tear is not available in, I think, Tri-City and the nearby
yeah.
cities.
So
So, our approach has always been TACE.
so tear. That's what I'm saying. TACE has been the approach. The one thing, the advantages of tear over the TACE is that you have less of the post embolization syndromes. They are less with the tear as compared to the TACE. Secondly, as it has been mentioned about the use in the portal vein thrombosis, it has been shown it has better with the tear rather with the TACE. And there are some studies where they have shown there bit little bit of survival benefit more with the tear as compared to TACE. But the problem with the tear is that the cost of single session is quite almost 3-4 times higher than the tear. So, and the availability of this technique
Availability
as
and
well.
accessibility are the challenges with tear. So, any role for radiation, SBRT in a patient with HCC? Dr. Deepak Singla, you can take this.
I mean, yes, but the size doesn't fit into that for SBRT.
No, any
SBRT. It's
indication
already
where
five.
you would like to offer SBRT first, followed by some other modalities?
I mean, provided if the lesion is single and it is less than 2 centimeters, and there I may prefer for the SBRT followed by systemic therapy.
So, any experience on the role of dissolving a clot or targeting a clot or thrombus with SBRT followed by using TACE? Anybody can take this. Dr. Yukanshu?
No, sir. So no experience about that. Sorry.
No.
Yeah, Dr. Sandeep,
I
I think.
think.
Yeah, I
Sir,
think
go ahead, please.
the role of SBRT has been emerging now for the HCC, and I think more and more I think we are seeing the radiation oncologists are coming up with this approach, and they are actually having a more experience in this sort of a setting, and especially that you mentioned about if there is a major vessel invasion or portal vein thrombosis. Then this is I think the SBRT is going to be the better approach in these patients that has been seen. And also the patients, if the patient has a ascites, that is also even in ascitic patients we can give SBRT. That has been seen that we can actually they can be taken for SBRT in that sort of a setting as well.
Yes,
So
for
overall,
highlight upon SBR, the role of SBRT prominently has come up in patients those who have portal vein thrombosis, where you can target maybe the thrombus and then followed by the local based approaches, that is intervention based approaches, whether it is TACE or tear. So, comments from all the panelists: what is the average number of TACE or ablation that you usually follow in your patients? I would start with Dr. Burhan.
so Dr. Sandeep, majority of my patients are they come in the you can say that metastatic. So, but I tend to refer these patients for TACE and to the Tri-City. It's not available
So the
locally
question is
or to
about
the
TACE
Louisiana.
refractoriness. When do you consider a patient as TACE refractory?
Yeah, if we see the definition for the TACE refractory, there are number of the definitions as of now they are not standards. But overall, if we see, they have been there are two. If there are 2 or 3 sessions, some of the studies have taken more or equal to 3 sessions of TACE, and if there is a no response in at least 6 months, then it is considered as a refractory disease or TACE failure.
Okay, Dr. Movin, your comments?
Sir, actually, in the tier 2 cities, I think these facilities are not available. And initially, I was in Delhi. I have seen lots of patients at Max with TACE and tear. And the refractoriness of the TACE and tear at Max, we used to have 2 to 3 sessions of TACE and tear. And if the AFP is constantly increasing, and after 3 to 4 months on the scan, if there is ability is also increasing, then they used to have it call it refractory.
Next slide, please. So this is about TACE versus TARE. As we have discussed, TARE is more suitable for patient with HCC with portal vein thrombosis because of the small size of TARE particles compared to TACE. Single TARE session is much higher of a cost, but it requires the cost of, if you consider the cost of hospitalization, pain control, treatment multiplicity, and toxicity, the overall cost of TACE, the TARE effectiveness is likely superior to be than that of TACE. So there is a much less risk of post-embolization. So these are certain advantages of TARE over TACE. Next slide, please. So we can also consider the TACE versus TARE in an overall analysis of patients in terms of survival. So overall, there is no survival difference between the two, but there is a longer time to treatment progression there. Next slide, please. So again, that the point that we were talking about is, next slide, please, is the role of SBRT. So go to the previous slide. Go to the previous slide. So that the point that we were we were trying to highlight was the role of SBRT in a local tumor control. That patient has a macrovascular invasion, patient has portal vein thrombosis or extension of the thrombus to IVC. So there probably you can consider adding SBRT and followed by the local ablative therapies. Next slide, please. So this is about how do you select between TARE and SBRT. Next slide, please. So addition of the systemic therapies will come in a while. Lenvatinib with loco-regional control therapies. So any comment upon what we are following nowadays, Dr. Deepak? Following TACE, what we are doing nowadays?
Now, I mean, if the patient is in the child A, I mean, and patient is affordable, and definitely I prefer the like immunotherapy plus bevacizumab.
No, I'm talking about a patient who has undergone ablation, that is TACE. Now, what do you do next in your practice, whether it is local ablative therapies, addition of lenvatinib, or you leave the patient on a follow-up?
No, I will be like first of all, I will start with immunotherapy and plus bevacizumab, IU plus and this.
So I will answer.
Okay, Dr. Yuganshu, your comment. Dr. Deepak wants to choose Vivasi with Atezo combination post-TACE.
Sir, there is no data for the same. We started with sorafenib, we used to give sorafenib after TACE, but we lenvatinib is an agent, but still data is not that mature that you can add it.
Right. So what nowadays what we are following is the addition of lenvatinib, which has again got a survival benefit of around 6 months. That is what I was trying to point. Post-TACE, if you give lenvatinib versus a placebo-based approach, you have got an overall survival benefit. So that is why majority of the clinicians, they tend to use TKIs along with TACE. Next slide, please. So this is about the trial that TACE with addition of lenvatinib and pembrolizumab. Any comments on the trial design, Dr. Deepak Bharti? I think the approach has been using ablative therapy with the local control or the systemic control with some of the immunotherapy and TKI based approach. So the overall idea has been use of a local ablative therapy with a systemic based approach. Next, yes, please go ahead.
So basically, point is that if you ask for the LEAP trial, they have followed all the solid sites. And similarly, I think based on that trial, they have wanted to explore the data for SEC also. Because it's the need of, or we have only active data with us and London only. And obviously, they want to choose TKI plus immunotherapy in the first go. Maybe they will get them more and more benefit in this subset of patients. And I think by choosing this site, as we know that in the LEAP trial, has shown excellent results in the endometrial and other solid sites. And similarly, I think it's very interesting to see the results, and I think result will be in the favor of LEAP trial only.
Yeah, please, next slide, go ahead. I think we all have been trying to modify our treatment protocols with the use of TACE followed by TKI or a TKI and an immunotherapy based approach. So this patient was offered TACE twice with a gap of 3 months. After 6 months, 5 centimeter lesion became 2.8 and 2 centimeter lesion remained unchanged. On evaluation, patient was found to have no esophageal varices, no ascites, no encephalopathy, and a Child-Pugh A6 liver function. Next slide, please. So suboptimal response to TACE. What next? Is this tumor TACE refractory? We have discussed. Next slide, please. How do you change from local to systemic? We have discussed this. How do you think TKIs are a better treatment option than immunotherapy? We have discussed this about TKI and a combination of TKI with an immunotherapy. Next slide, please. So are you concerned about that? We'll come to the trial I Am Brave study. Next slide, please. So this patient, after giving TACE and TKI, this patient develops TACE refractoriness, which is again defined as 3 or more TACE procedure within 6 months, advancing to PVTT and an extrahepatic spread. So this is about the definition of a TACE refractoriness. If you have 3 different sessions in 6 months, increasing AFP leading to PVTT or an extrahepatic spread. Next slide, please. So provided this patient has become TACE refractory, this patient was started on an atezo-bev combination. So before the use of atezo-bev combination, what all do we decide? One was the endoscopy. What has anybody used this combination in their clinical practice, and what have been the outcomes? Dr. Burhan, any comments?
Yeah, I think I have used in around 10 odd patients this combination in HCC in unresectable in metastatic setting, and overall it is a well tolerated regimen, and the responses have been good, and we can say that out of the 10 patients, almost closed around 5 to 6 patients did respond, showed the response to the combination therapy.
Dose modification required for bevacizumab while you are treating the patients?
I tried to be that actually this trial design was using the 15 milligram per kg body weight, but the problem that I faced was a little bit about the cost once because we knew that because assistance was the thing that was provided. So we used to be it was around closed around 10 to 15 milligram per kg. So most of the time we used to be more towards the 10 rather than the 15. So that was my approach. But overall, I did not face much of a problems. The conventional toxicities that were with the bevacizumab, especially hypertension, and that was seen mainly.
So Dr. Deepak Singla, any comments on the use of atezo-bev combination and the dosing schedule?
Yeah, currently I'm having 5-6 patients of HCC running on this protocol. I did not face any much difficulties, and it is very well tolerated.
You are using 15 milligram per kg?
Yes. But till now I'm using 15 milligram. At least initially in the beginning I'm using it. Eventually if the patient is not tolerating that, and then I may reduce. But till now I did not face any problem so far. And of course, as you said that before starting that we need to rule out the varices and everything. So after that I'm using it.
Okay. Any comments, Dr. Deepak Bharti?
Yes, sir. So I want to share that I till now I have in my practice I choose 3 to 4 patients. One last to follow up after 2 or 3 cycles. But I just want to share about my one patient. He still continuing, and presently he has 19 to 20 months on ATN-web, and I'm giving full dose of ATN-web. And I think touching 2 years is on this dose, and excellent response rates are there. And one interesting point regarding this patient is that this patient has received initially TACE. He got DFI of touching 1.5 year on post 2 sessions of TACE. Then he recurred. Then I have put her on ATWeb, and after that she has continued on touching 20 months and is still on that.
Any challenges with this combination?
Nothing.
Okay.
So, sorry to interrupt. I think we are exceeding our time.
In another 2 minutes. We'll conclude in another 2 minutes.
Yes,
so this
please,
patient received atezo-bev combination with a good response, and the CT scan showed no lesions after 9 cycles. The patient is still on maintenance atezo-bev combination. Some amount of hypertension, occasional fatigue and weakness. Next slide, please. So how would you have managed this patient differently? I think we all agree that the patient was managed very well with TACE and use of local therapies and systemic therapies followed by systemic therapies. Next slide, please. So that is all I have from my side. Next slide, please.
So, Dr. Sandeep, one point is that my patient is already hypertensive. So, I have to increase the dose of antihypertensives after 1 year.
Yeah, exactly. Hypertension is one, proteinuria is one, bleeding episodes are the other complications that one needs to look at. So it can be used as a bridge to transplant also, that we have already discussed in our initial slides. Thank you. I thank all my
Thank you.
panelists. Thank you, Dr. Nitish, for providing the opportunity. Thank you.
Thank you, sir, for the wonderful moderation of the session. So I have a couple of quick comments. So we tend to miss out that infiltrative SCCs does bad. So even on what we see on the triple phase CT, if it is an infiltrative disease, it is not going to respond much. And we have even seen the biopsy proven infiltrative diseases are worse because of the mutational analysis. So that is one thing. And I tend to add a biopsy from the liver lesion to know if that nature of the disease I'm dealing with. Maybe people are not practicing. We tend to have a different opinion depending upon the biopsies. Otherwise, and other important thing is if we have this the launch data which says add addition of lenvatinib post ACE, which has shown a greater benefit. The data for atezo-bev using atezo-bev, I'm not sure it is going to help us or not, because that is an upfront setting. And now post lenvatinib, if we are using, the responses might not be that great. So that is a challenge, that after lenvatinib used in the first line post ACE, do we tend to use immunotherapy? But yes, off trial, yes, I think most of us will agree with me that we are still using it.
Yeah, exactly. I think your points are well taken.
Thank you, sir. So I think we'll conclude this session. So now we'll move to the next session, which is sponsored by Intas, and it is a talk on S1. Basically, I'll be taking this talk. So S1 in the GI malignancies has come up with a bang on the buck, because it was not available previously, and now it has started showing that yes, there is one more option for our patients which is available and which has slightly better tolerability and almost equal benefit. So I would like to share my screen. I hope my screen is visible.
Yes, sir. Visible.
Yeah. So I'll be talking about S1 in GI malignancies. So this is the overall outline of the talk, molecule overview, some a little bit of about the mechanism of action, trials in the GI, colorectal, and the biliary system. So it is basically a fluoropyrimidine analog, which we know inhibits the RNA synthesis and the function inhibit thymidinase synthetase activity, and then it gets incorporated into the DNA, disrupt the DNA prolongation or the RNA prolongation. So this is the normal process how it goes. And once the fluorine molecule attaches at the fifth position, the chain prolongation does not happen. So why that was an unmet need? Because we have seen the efficacy of the other drugs in the second line or in the third line was poor. So better tumor activity. Then the safety of the drugs was not that great. So it has a lesser side effect profile and good tolerability. And also the compliance. If we tend to add regorafenib, 4 tablets are to be given. If we tend to give capecitabine, again 4 to 6 tablets are to be given per day. So there the compliance to the treatment becomes better because the number of tablets are slightly lesser. Not too less, but slightly less. So mode of action is, we know Tegafur is the prodrug of 5-fluorouracil. So it is an increased convenience, and directly it converts into 5-fluorouracil, which is the active molecule. And oteracil, what does oteracil do? It reduces the toxicity by reducing the unwanted metabolites of 5-fluorouracil in the normal mucosa, and then Gemarasil, what it does is it increases or enhances the active metabolite in the system by inhibiting the DPD enzyme so that the 5-FU, which is present there in the active form, stays in the system and has a enhanced efficacy. So this is the overall overview of the mechanism of action. So tegafur, which converts into 5-fluorouracil, if it in the tumor cells by orotate phosphoribosyl transferase converted into 5-fluorouracil monophosphate, which has the anti-tumor activity in the normal cells. This conversion is stopped by oteracil, and also when it gets catabolized and inactive, it has to form something called fluoro-B-alanine. So this is done by the DPD enzyme, and Gemarasil inhibits that, so it increases the overall effectiveness and reduces the toxicity. So S1 has been approved in the first line for advanced gastric malignancy, in the second line in metastatic colorectal, and also in the first line probably in the biliary malignancy also. So the doses of S1 varies. As per the trial, it has been 25 milligram per meter squared twice daily for to be given for 4 weeks with 2 weeks of gap. And there has been few trials which have divided the dose of S1 to 3 weeks followed by 1 week of gap. So this is the probable dosing which has been given. So this cycle, as of this thing, the cycle repeats every 4 weekly, or the cycle repeats every 6 weekly. So when it is given along with cisplatin, cisplatin is given at 75 milligram per meter square every 28 days. So dosing reduction, we tend to reduce it by 20% each time with the toxicity. So coming to the dose of S1 in the gastric malignancy, then the colorectal. So when we give it in the gastric malignancy, the starting dose is 25 milligram per meter square. Toxicity is reduced by 5 milligram per meter square, and then the second reduction. If we are using it as a monotherapy, the dose is 30 milligram per meter square. And mind it, this dose of 30 milligram per meter square is for 14 days with 1 week of gap. Whereas in S1 with cisplatin, it is for 3 weeks followed by 1 week of gap. And when we are giving it with irinotecan or oxaliplatin, the dose is 25 milligram per meter square for 14 days followed by 1 week of gap. So this is the usual duration of the treatment which has been seen. So one thing which is important to remember is when we tend to give capecitabine, capecitabine is usually given along with the meals. So for S1, we have to understand that it should not be given with the meals. It should be either given 1 hour prior or at least 1 hour after the meal. And coming to the special precaution or for a specific population in kids who are under the age of 18, it should not be administered, or in elderly who are more than 70. The dose adjustment standards are not very known, but still can be given. So in renal dysfunction, it is to be avoided. In a severe renal dysfunction, mild no dose adjustment. And in hepatic dysfunction, no dose adjustments have been recommended. The common side effects are nausea, fatigue, vomiting, anorexia, and diarrhea. So coming to the evidences, what evidences do we have in the advanced gastric malignancy? So this was the FLAGS trial, which gave us S1, which was indicated in the advanced metastatic first-line setting. So FLAGS was the initial phase 3 trial, which was conducted in 23 countries. Almost 1,000 patients were included, and it compared cisplatin plus S1 versus 5-fluorouracil plus cisplatin. So the primary endpoint of this trial was the overall survival. And if we see the Kaplan-Meier curves, they're perfectly overlapping each other. There has been no significant difference. So similar overall survival and similar PFS. Only important thing was the hematological side effects were less. The cytopenias were less, the stomatitis and diarrhea was slightly more than 5-fluorouracil and cisplatin combination, and the treatment-related deaths were extremely low. So cisplatin plus S1 resulted in a significant reduced rate of severe side effects with a equal and overall survival. So this is the overall toxicity profile of the trial. So S1 had lesser number of patients with neutropenia, complicated neutropenia, again less than half. Then stomatitis still less, but yes, we know S1 is slightly notorious in this category. Stomatitis and diarrhea are slightly more. So coming to the next trial, which was a meta-analysis of S1 based versus capecitabine based chemotherapy in advanced unresectable gastric malignancies, and the primary endpoints were overall response rates and time to progression, followed by overall survival. So the overall response rates were almost similar as the capecitabine. The overall survival was also in the same range with the capecitabine. So it was shown with this meta-analysis that S1 is non-inferior to capecitabine and has a better safety profile. The equivalent grade 3 or grade 4 hematological side effects are hematological toxicities are almost the same. S1 hand-foot syndrome is less. So then came the adjuvant trial, which was ARTIST-2. So it compared post D2 dissection or D2 gastrectomy. The patients were randomized to 3 arms: only S1, S1 plus oxaliplatin, and S1 plus oxaliplatin with S1 and radiation. So these were the 3 arms, and the primary endpoint of this trial was disease-free survival. So looking at the results, so we see that the S1 alone arm is quite low than compared to the S1 in combination with oxaliplatin or along with radiation. So though there is no significant difference when radiation is added, but this data continues to go further, and it has been seen that if the patient has a high nodal burden of the disease, the addition of radiotherapy does slightly improve the overall survival. So this is the Prodigy study, or the phase 3 Prodigy study, which was neoadjuvant docetaxel, oxaliplatin, and S1 in a neoadjuvant arm for 3 cycles versus upfront surgery. So again, this trial, though the trial design is slightly odd, where a patient is getting the neoadjuvant chemo surgery followed by the adjuvant therapy, so versus upfront surgery followed by adjuvant. I would have liked it if it would have been compared with a neoadjuvant arm again. But the overall survival results, if we see that, shows that definitely there is a benefit by 6% in the PFS, and also overall survival, which was almost the same. So not a great improvement in the overall survival, but it is still a tolerable regimen. Post-operative pathological stage, and the patients who received SCS had a pathological complete response of 10.4%. So this was a new thing what we see with this trial, that there was increased pathological CRs compared to the other neoadjuvant chemotherapies. So then this is the basic comparison between S1 plus oxaliplatin versus S1 plus cisplatin. So which has compared that if we replace cisplatin by oxaliplatin, the effectiveness is also similar, and it was a non-inferiority trial. So we can see the Kaplan-Meier curve graphs are just overlapping each other. The median overall survival with SOX is in 14 months versus cisplatin plus capecitabine is, cisplatin plus S1 is 13 months. So not a great difference except for the safety, which was greater in SOX. So coming to S1 in colorectal malignancies, so this was an initial trial which compared S1 versus Kpox, SOX versus Kpox in the first line setting. the non-inferiority phase 3 trial, which had almost 340 patients, and the dose of S1 was taken to 40 milligram per meter square twice daily for 14 days. So we can see the median overall survival does not differ much, but look at the toxicities. The diarrhea and stomatitis are slightly greater in SOX compared to hand-foot syndrome, which is less than the half. Febrile neutropenia is almost the same. Those modifications are almost the same. So again, this is a soft trial, not the soft and text what we talk about in breast. So here in soft trial of the colon, we have compared SOX plus bevacizumab versus FOLFOX plus bevacizumab. So in this randomized phase 3 trial, it was comparing these two arms with both the sides of the patients were fairly well matched. And if we see the overall survival and the PFS, it is fairly overlapping each other and no significant difference was seen. So median PFS was almost the same. So it met the inferiority margin, and we could say that SOX was non-inferior to FOLFOX along with bevacizumab, but yes, it was superior in the safety. So look at the neutropenia rates, 34 versus 9, and hand-foot syndrome was almost the same. So neutropenia, which always keeps us on our toes, it was quite less with SOX. So coming to FIRIS study, So the FIRIS, it compared whole PD versus IRIS in the second line, and again the similar benefit. So S1 can be replaced in case of in FOLFOX also in case of instead of 5FU in both the chemotherapy regimens. So again, the similar data. So overall survival benefit, you can say almost the same. PFS is almost the same. The side effects are better with SOX or IRIS. So when we add on anti-EGFR therapy, the Jacaro trial and the Japanese trial, they have shown that in adding of cetuximab improved the EFS, PFS, and also the response rates to certain extent when it is added in the first line, but even in the second line of therapy, though there was not a comparative study and the number of patients was slightly less. So when we talk about S1 tolerance, so when it is given alone, the compared to capecitabine in the Salto Dutch trial, the tolerance has been great. The hand-foot syndrome of any grade was almost approximately 45% with S1 versus 73% with the capecitabine, and grade 3 was almost 5%, 3 times less than the capecitabine group, though the diarrhea and anorexia was slightly greater. So again, the same comparison with addition of bevacizumab and the similar result again. So PFS almost overlapping, and if we see the incidence of developing hand-foot syndrome grade 2 and grade 3, very high with the capecitabine group, and with S1, the difference is quite low. So coming to the evidence in biliary malignancies, so adjuvant S1 versus observation, ESCOT trial has shown that there is quite a lot benefit of addition of S1. We initially should have compared it with capecitabine as per the BILCAP trial, but this trial design has compared it with only follow-up. So a patient who has undergone surgery followed by no adjuvant treatment versus adjuvant S1. So patients received S1 for 4 cycles, where the dose was given for 4 weeks followed by 2 weeks of gap. So the dose was 40 milligram per meter square twice daily. So all the patients from T1, N0 and T2, N0 were included. Mostly all the patients except for T1, N0, M0. So they were included in the trial. So surgery alone versus adjuvant S1. So the primary endpoint was the overall survival, and patient characteristics was fairly well matched. So if we look at the results, the median follow-up was 45 months. The overall survival was significantly longer with adjuvant S1 than surgery alone, with a hazard ratio of 0.69. So the the relative risk to death was reduced by approximately 31%, and also at if we see the recurrence-free survival was also reduced by almost 21%. The relative risk of recurrence reduction was reduced by 21%, and at 3 years the RFS was 50.9 with surgery alone versus 62.4 with S1 in the adjuvant setting. Main grade 3 side effects which were seen was infection, diarrhea, and yes, there was few dose reductions or interruptions present. So this is the Kaplan-Meier curve which shows the surgery alone and versus adjuvant S1. The graph starts to separate approximately at 1.5 to 2 years, and 3-year overall survival, there is approximately a delta of 10%. So most of the subgroups does better except for a node negative group, but in a combination when it is node negative and higher T stage, the benefit is still present. So in the relapse-free survival, again, there is a significant difference of 12%. So the adverse effect we all know in the adjuvant setting, we'll see slightly more diarrhea, tiredness, fatigue, anorexia, and stomatitis. Anemia and decreased platelet count and increased bilirubin are slightly common, but not in the grade 3 or grade 4. So the conclusion is, as per this trial, the adjuvant S1 therapy leads to a significantly longer survival than surgery alone and can become a standard of care in the resectable BTC category. So then there are few other randomized trials where the S1 has been added to gemcitabine and cisplatin combination, and the triple drug combination has scored better over the doublet combination, except for the toxicity profile. The grade 3 toxicity was slightly greater in the triple drug regimen compared to the double drug or a doublet regimen. So this is the comparative Kaplan-Meier curves where the graphs keep separating from approximately about 3 to 4 months. The overall survival data and the progression-free survival is slightly, I can say, immature, and we need to follow them up for a longer time to know if there is a significant benefit. So the safety is the first. It is the first regimen which has demonstrated a benefit in the overall survival with over the and the response rates over gemcitabine and cisplatin combination, but with the higher toxicities. So then again, it was the Fuga BP trial, which was again a Japanese study where the same comparison was evaluated. But in this study, it was gemcitabine plus cisplatin versus gemcitabine plus S1. So this comparison compared in 350 patients has shown that the responses have been almost similar, and this trial was a non-inferiority trial which showed that gemcitabine plus cisplatin is almost or gemcitabine plus S1, rather I should say, is almost similar to gemcitabine plus cisplatin. So median PFS in both the arms were almost the same. The clinically significant side effects which were observed were 35% in gemcitabine plus cisplatin arm versus 30% in the gemcitabine plus S1 arm. So the overall survival and the PFS are fairly overlapping each other, no significant difference. So this tells us that 5-fluoro or fluoropyrimidines are the backbone of chemotherapy in the GI cancer. Orofluoropyridines include pro-drug capecitabine, tegafur, tegafur, uracil, or the triple drug combination are active in most of the GI malignancies. Adjuvant S1 has led to a longer overall survival than surgery alone in the BTC, and also has potentiality to be considered in the first line and in the second line and beyond for the gastric and colorectal malignancies. Thank you. So if there are any questions, I can take, or we can move to the next session. So our next session is sponsored by AstraZeneca, so which will be a real world experience of durvalumab in biliary malignancies. I would like to invite my speaker, Dr. Alok Goyal. He's associate professor and head at Homi Bhabha Cancer Hospital, New Chandigarh. Over to you, sir.
Thank you, Nitesh, and thank you, organizer, for this opportunity. As we are already running late on time, I will try to be quick. If you have any questions, I will be happy to answer them. So, can I ask somebody to please project my slides? Is there somebody who can project my slides?
Yes, sir. We will.
So just a disclaimer before starting, these slides are provided to me by the organizers, not tweaked much with the slides, but give a good real world experience of using this molecule in BTCs, which we know have a poor prognosis. So can we go to the next slide, please? So if we look at some data from India, we can see that it's although a rare tumor, not so rare. There are almost 40,000 cases of biliary tract cancer registered every year in India, and the rates are higher in Gangetic belts, as we know, and other rates are higher in Assam and Delhi, maybe because of referral bias which occurs in Delhi from that Gangetic belt. And what is concerning is that almost 90% of these tumors are diagnosed in unresectable or advanced stage, and we don't have any screening test as of now to pick them in an early stage. And when we pick them in advanced stage, their survivals are dismal, and the 5-year survivals are less than 10%, and the median OS is in the range of 8 to 10 months. The majority of tumors, biliary tract cancer, which are in India, are gallbladder with a minimal of intrahepatic and extrahepatic cholangiocarcinoma. So when we look at a data which is mostly from Western countries, where there is a majority of cholangiocarcinomas, we need to interpret those data a little cautiously, because the percentage of gallbladder tumors which are included in these trials are much lesser than what we see in our country. Next slide, please. I will not go into diagnostic investigation for BTC in detail, but we know that we need to have a staging first. So we do when a patient comes with a pain abdomen, which is the most common symptom, we do ultrasound. And when we see a mass or thickening in gallbladder, we go for other staging investigation like CT and MRCP when it is required to rule out cholangiocarcinoma. And to rule out distant met, we do a PET scan or a CT of thorax and pelvis when not done. And then we do the investigation to check the fitness for chemotherapy. Next slide, please. And so, like any other tumor, we have, when it is resectable, the treatment of choice is surgery, which gives the best possible outcomes. There's not much role of radiotherapy or a combination radio chemotherapy, which is seen in these tumors. The trials have shown dismal results because of toxicities and not much benefit. And when it is non-resectable, that the treatment option was only chemotherapy a few years back, until when we now have immunotherapy, which is in terms of Imfinzi, which has come into picture and become a category 1 indication in various guidelines. And now we have other targeted therapies, like we have data of HER2 targeted therapy in biliary tract cancers, which can be used apart from other molecules like NTRK and other markers which can be used in patients who have some molecular markers. Next slide, please. So this is the first case. So it's a 64-year-old male presented with pain abdomen for around a month. Initially, as anybody will go, consulted local hospital, was given some conservative treatment, but the pain was not relieved, and then a CT scan was done. So the CTs, next slide, please. The CT's abdomen showed a distended gallbladder along with irregular interluminal soft tissue thickening along the anterior wall of gallbladder around 7 into 3 centimeter. There was no invasion into liver parenchyma or any surrounding structure. A triple phase CCT abdomen was again done, which showed a GB mass and anterior wall of gallbladder around 3 into 3 centimeter, and a PET scan showed a metabolically active soft tissue mass in body of gallbladder without any metastasis. Next slide, please. So a diagnosis of a carcinoma gallbladder was made based on this, and a radical cholecystectomy was done as we all do in a case which is resectable. We don't do a biopsy, and based on the radiological picture we do. And the HPR showed it to be a well-differentiated adenocarcinoma, and the P stage was T2B because it was invading the perimuscular connective tissue. And next slide, please. And there were no lymph nodes. So adjuvant chemotherapy plan, this is not the case which I have treated. So the adjuvant chemotherapy plan was made with Gemox. There will be some questions on the choice of the chemotherapy which is there in the absence of the data for Gemox. But we all, as I have already discussed, because most of the data is for biliary tract cancer, and Gemcis and Gemox being a first-line therapy in most of these tumors, in advanced tumors, we all are guilty of using this adjuvant chemotherapy regime in a lot of our patients of gallbladder cancer, despite phase 3 randomized control data to see the effectiveness of this regime. Next slide, please. So this is the only randomized trial which showed a benefit of any drug, which is capecitabine in patients with resectable biliary tract cancer, which showed us improvement in survival. But as I said again, this subgroup is mainly a biliary tract cancer and had very minimal amount of gallbladder cancers. Next slide, please. As we know, this is study from TMH only, and as we see that we try to compare whether Gemcis and Gemox has any difference, and we do a match pair analysis, and it was found that Gemcis and Gemox are equivalent in terms of their survival and benefit when used in metastatic setting. Mind it's metastatic setting with some differences in toxicities between the two agent with lesser toxicities with cisplatin, making it a more convenient regime. But in terms of efficacy, there is nothing to choose between these two regimes. Next slide, please. So this is again a trial which is quoted when to say that Gemox is not a regime to be used in adjuvant setting, saying that it's a negative trial. But again, to highlight the same, that most of the patients are biliary tract cancer, and we know that the biology of biliary tract cancer and gallbladder cancer is different, and we cannot totally extrapolate the results to gallbladder cancers. Next slide, please. So this patient, after surgery, didn't receive any adjuvant therapy. After 12 cycles of adjuvant therapy, lost to follow-up, then presented again after around 2 years with again fever, pain, abdomen, and jaundice. A CT was done at that time, which showed a soft tissue mass in the posterior wall of CBD with liver infiltration. And there was a mass again at the distal CBD. There was some renal cysts. Next slide, please. The MRI again showed a well-defined soft tissue intensity lesion, which is abutting or involving the lateral aspect of proximal CBD. And there was dilatation of CBD, pancreatic duct, and interhepatic biliary reticle because of this thing. And there is some sludge with calculus in distal CBD. And EUS was also done, which showed ampullary mass with dilated CBD and pancreatic duct. Biopsy was done, which is cellular dysplasia, which we also find a lot of time when we do in these type of interhepatic cholangiocarcinoma lesions, we sometimes had difficulty improving these lesions. CA 19.9 was high in view of this obstruction. A ERCP plus stenting was done, and a PET-CT which was done. Next slide, please. Next slide, please. The PET-CT findings are missing. So it showed it to be a metastatic, unresectable metastatic gallbladder cancer. So if you look at this, is the older NCCM version, we showed that this was the preferred regime. But after that, this trial, which we'll be discussing now, Gemcis durvalumab become the first-line therapy in metastatic setting. Next slide, please. So this patient, based on this, was planned for durvalumab plus Folfox. So this again not done by me. So the Folfox regime, the choice of Folfox as a combination with durvalumab is not based on evidence. and the evidence is for adding Gemcis with durvalumab. But this patient anyhow received durvalumab 15 mg with FOLFOX regime 2 weekly for 12 doses. Next slide, please. So we look at that Topaz 1 trial, which is the one which showed that the combination of durvalumab to Gemcis, the phase 3 trial which showed the benefit of this immunotherapy along with Gemcis. So this included patients with locally advanced or metastatic bladder cancer, both ISCC, extrahepatic cholangiocarcinoma, and gallbladder cancer, who have recurred more than 6 months after curative surgery or large dose of adjuvant therapy, taking a group which is slightly less resistant to chemotherapy with a more than 600 recurrence and a standard ECOG PS021. And most of our patients who we've seen at the clinics, around 50 to 60% of gallbladder patients are PS2. So this was not included in this trial, and only this was one thing which is away from real world data. These patients were randomized 1:1 into durvalumab with Gemcis for 8 cycles versus Gemcis alone for 8 cycles, followed by durvalumab maintenance until progressive disease, and the primary endpoint was overall survival. Next slide, please. So there was not much difference between the baseline characteristics of the patient, and it is what we see in clinics normally. And if we look at the disease status, most of 80% of patients were initially unresectable, and recurrent disease was almost 20% in this trial across the groups. Next slide, please. And this is the curves which came up with the Kaplan-Meier stuff, showing that indeed there is a benefit even at a 2-year points with addition of durvalumab to Gemcis, with a 2-year OS increasing from 11.5% to 23.6% with a hazard ratio of 0.76, and the confidence interval well below unity, showing that yes, this improved survival. This was the first drug to improve survival in biliary cancer after a long time. Next slide, please. If you look at the forest plot to see whether what type of subgroups seems to benefit from this addition, and we see more or less all of the subgroup seems to benefit from this therapy. The only thing I want to highlight is that if we look at the primary tumor location, which is gallbladder cancer, which was a pre-stratified fracture, the upper limit of confidence interval crosses unity, but we need to see that the confidence interval is very wide, 0.64 to 1.25, giving us a lesser confidence to believe that this will be due to statistical significance. Otherwise, it seems that Gemcis durvalumab seems to work across the board. Next slide, please. And if we look at the secondary endpoint of PFS, the PFS also seems to, there was significant improvement in PFS, which was statistically and clinically significant with addition of durvalumab to Gemcis combination. Next slide, please. And similarly, the forest plot for the PFS is almost a mirror image of what we saw for OS, showing that there is improvement across the subgroup. Similarly, for the similar as OS, the gallbladder cancer group, there is a similar type of hazard ratio, and the interval, the confidence interval or the higher limit is more than 1, similar to what we have discussed with the OS also, but difficult to say from the subgroup analysis because the hazard ratio and the wider confidence intervals. Next slide, please. So this patient had some partial response to the combination of Gemcis durvalumab after FOLFOX plus durvalumab after 4 cycles, and he was continued further on this regime. Next slide, please. So this patient was then shifted from durvalumab from FOLFOX to capecitabine alone, and durvalumab was continued along with this thing. Next slide, please. This patient is still, as per the last update, is doing fine on capecitabine per durvalumab, is being on this therapy for past 1.5 years. If we look at the next case, it's a 68-year-old female presented to OPD in September 2023 with pain in right hypochondrium for a period of around 2 to 3 months, had some decreased appetite and dyspepsia. Ultrasound was done, which showed a large gallbladder mass, almost 9 centimeter. Next slide, please. CT showed a large gallbladder mass, which is building into subhepatic space and impending perforation. CA 19.9 was normal, CA was slightly higher, and endoscopy was done, which showed a large grade B esophagitis. Next slide, please. This is the baseline scan, which we see a large gallbladder mass, which is indenting the liver. Next slide, please. The PET scan showed ill-defined hypermetropic peripheral lesion seen arising from gallbladder fossa, which is infiltrating the liver, and there is a hepatic mets which is there, showing that's a metastatic gallbladder cancer, and the FNAC which was done showed adenocarcinoma. Next slide, please. So this was a patient of metastatic gallbladder cancer, and as we have discussed, next slide, please. So as we have discussed previous slides also, the category 1 indication in biliary cancer which are unresectable metastatic is a combination of gemcitabine plus durvalumab. Next slide, please. Next slide, please. So this patient was planned for injection durvalumab 1500 mg along with gemcitabine for 6 cycles. After 4 cycles of durvalumab with chemotherapy, the PET-CT showed a partial response, and the patient was continued on this combination. Next slide, please. The assessment scan showed a partial response. Next slide, please. Similarly, the patient was continued, and even the January scan showed a persistent partial response with further reduction in the mass. Next slide, please. So we look at apart from the OS and PFS, other secondary endpoint were overall response rate, and we can see that almost as compared to GEMSIS, almost 1/4 of the patient will have a response rate when durvalumab is added to GEMSIS combination. Next slide, please. And it is good to see that even this response is persistent for more than a year, that almost 1/4 of the patient will have a persistent response for more than a year as compared to only 15% with GEMSIS alone. Next slide, please. And as is true with any immunotherapy combination which we have seen across the tumors, the patient who responds to immunotherapy continue to respond better. The curves keeps on separating even when the immunotherapy is stopped in some of the cases. And this is true with durvalumab also, that the patient who were responding keeps to respond for a longer time. Next slide, please. And what is heartening to see that like other immunotherapy trials which we have learned now, that addition of immunotherapy to chemotherapy, the majority of side effects are due to chemotherapy, and immunotherapy combination doesn't increase grade 3, grade 4 toxicity significantly, as we've seen with this trial also. There were not a significant increase in grade 3, grade 4 toxicities attributable to combination of durvalumab. Next slide, please. And these toxicities were mainly due to chemotherapy and are manageable as per the PS of the patient and the general condition of the patient, as we do with chemotherapy alone. Next slide, please. And most of the grade 3 4 toxicity are hematological, and nothing specific or a specific grade 3 grade 4 toxicity was seen with addition of durvalumab to chemotherapy. Next slide, please. And if we look at the immune-mediated adverse effect also, the grade 3 side effects were also very less, around 2.4%, and were not a very major problem to deal with. Next slide, please. So to summarize, if we look at the overall survival, which is the primary endpoint of the trial and which is considered a gold standard for endpoint to define the efficacy of any therapy, there is a significant improvement in overall survival when we add durvalumab to GEMSIS combination, and it is statistically as well as clinically meaningful improvement. We look at the subgroup seems to benefit across the subgroups. Safety doesn't add any particular safety signals or adverse effect which is of concern apart from chemotherapy. And we look at the real world data, which is coming more and more now. It seems that it mirrors what we see in a trial also, and in the real world we are using it more and more even in PS2 patient, and we see that the effects are seen in patients who are even PS2, showing that this combination as per trial also in real world also seems to reflect the results what we have seen in a trial. Next slide, please. Thank you. I will be happy to take any questions.
Thank you, Dr. Alok, for this wonderful talk. Durvalumab definitely has given us the edge in treating biliary malignancies, because we know these are the horrible tumors what we deal with. So I think we would like to discuss the questions in the panel discussion itself. And I would like to invite Dr. Aditya Sareen, who is a consultant in Department of Medical Oncology at Sir Ganga Ram Hospital, New Delhi. So we will be having a panel discussion on targeted therapy for unresectable and metastatic biliary cancers. Over to you, Dr. Aditya, and you can please invite your panelists.
Yeah, thank you so much, organizers and Dr. Nitesh, for this opportunity. And I will like to invite my panelist, Dr. Ankur Varshne, who's a consultant of medical oncology at Medanta Hospital. Dr. Ankur, are you there? Okay. Dr. Mohit Saxena, who's a senior consultant medical oncology at Marengo Asia Hospital, Gurugram. Yes.
Hello, sir.
Hello, Ji. And Dr. Kripa Bajaj, medical oncologist at Baswat Karam Indo America Hospital, Hyderabad. Dr. Kripa Bajaj.
Yeah, I'm in actually.
Okay. So, Dr. Akanksha Chaudhary.
Yes, I'm there.
She's a assistant professor in medical oncology and hematology at AIIMS Bhopal. So let me know, organizing team, when Dr. Ankur Varshne joins. So till the time I have 3 panelists. And okay, so let me just share.
No issues, Dr. Aditya, I'll be there. So
Oh, perfect.
he joins, and I think we would like to restrict it for 20 minutes and have a quick discussion on the cases.
Sure, sure.
Thank
Yes,
you.
absolutely. Yeah, just a second. Let me just open up the PPTs. So I think my slides are visible. So we'll be discussing on the genetic alteration and targeted therapy in the unresectable and the metastatic breast cancer. So coming on to Dr. Kripa Bajaj. So let's start with you. You are practicing in Hyderabad. So out of 100, what is the presentation of intrahepatic, extrahepatic, and gallbladder in your practice?
So my predominant practice out of 100, like put together all cholangiocarcinomas, or you want to just say 100 cancer patients in
So
general?
rough figure, how much load are you guys handling? And out of those biliary tract cancer, what is the percentage of the tumors coming with the GB, then cholangios, then intrahepatic or cholangios? So just a brief
Right.
Yeah.
Right. So extrahepatic cholangiocarcinoma, like usually periampullary apart, like I would say, so almost like out of 100 in general cases, I would see 1 or 2. And
Okay.
gallbladder cancer, out of 100, I would say like 4 to 5 cases we are seeing. All are like almost metastatic and locally advanced. And intrahepatic, it's like a rare, I would say. Compared to extrahepatic, it is slightly better. But compared to gallbladder cancer, intrahepatic, I would say out of 100, only 2 cases will be a intrahepatic cholangiocarcinoma in general. But in general, biliary tract, I do see almost 80% of the cases, I do see gallbladder only.
Gallbladder
And intrahepatic, I would say 10 to 15%. And again, extrahepatic cholangiocarcinoma also comes to 10 to 15%.
So over out of 100, if total oncology, so biliary tract cancer contributes to 10% of your practice, right?
8%, I would say 8%.
8%. Okay.
Yes.
Dr. Mohit, how about you?
Yeah, I think more or less percentage will be same. I think it is almost not more than 10%, that's for sure, including all 3 types. Of course, we see gallbladder more common in female and cholangio in male. And if you talk about the presentation, that I would like to say gallbladder, many of time it is diagnosed by the removal of the gallbladder by lab coli, and then it comes out to be gallbladder cancer. Then there is revision surgery is required. Sometimes it is like the presentation, sometimes it is the presentation that after cholecystectomy there is some. I'm sorry, there is. Yeah.
Okay. So, Dr. Akanksha, how about you? The main question I want to ask, what about intrahepatic cholangios at your center?
It's rare only, but I'm getting a lot of biliary tract cancers. I mean, out of 100, almost 30 to 40% gallbladder cancers I'm getting. And most of them are in locally advanced or metastatic, but quite a few number is also there in neoadjuvant and adjuvant setting.
So see, that's the thing that I wanted to highlight, that from the Western data, that whatever we are practicing, mostly what we are seeing is mostly gallbladder cancers. And whenever these trials are being planned over there, so they're mostly the most common component is of the cholangios, and that too of the intrahepatic, followed by extra, and the percentage of these boils down. So
सही है, घूमते रहोगे तो लेडियां दिखाई
so
घूमते
can
रहोगे
we,
तो लेडियां दिखाई देती रहेंगी।
can we move?
नहीं
Yeah. So that is obviously because of the demographic and geographical changes that we are seeing. And Dr. Mohit, how many patients with the metastatic biliary tract cancer are you seeing are having an actionable mutations in your practice?
In my practice, I think it is not more than 10%.
Not more than
Predominantly in
10%?
the biliary tract, I think most commonly I see HER2/neu,
Right.
and rest are quite rare.
Okay,
It's,
Dr.
of course,
Akash, I
try
will
to
keep on
convince
asking,
everyone,
and we'll be going quickly because time is short and we have a lot to discuss and lot to cover. So, Dr.
Okay.
Akanksha, how about you? Molecular actionable targetable mutations in your practice?
It's quite difficult to do these tests in government sector that I'm working. In fact, I wanted to bring this to the board of the panel from our hospital. So hospital authorities, in fact, objected. They are telling this test itself is causing 1 lakh rupees. And for that is well known that metastatic GB has a bad prognosis. So why do you want this to be incorporated in our this
That
thing?
you just want a HER2/neu by IHC. I think that can be done over there.
Yes, sir, that we do, but definitely I am also thrilled by these lot of FGFR RET inhibitors that are being used. So I did get for one of the
Right.
patients, and we got this thing TMB moderate in that patient, and PDL1 CPS score was 2.
And okay, so Dr. Kripa, how about your practice, and what's the percentage of patients presenting or you are diagnosing them with the actionable mutations?
Actual mutations hardly, I would say, less than 5%. We, as rightly Akanksha ma'am, like I used to work in a previous in a mixed place where like general as well as private, even the private in general, whatever we have done in the private patients, hardly anything I mean, all these things like what you represents are really fancy. I do really look for HER2 actually, most of the times. But
Right.
till now, I found only this MS. I have one patient luckily. From
Yeah.
past 2 years, he's doing really well.
Right. So, Dr. Garg, are you there?
Yes, Dr. Rajat.
So, NGS upfront versus NGS after failure of the first line.
No data at present. If possible, upfront. Otherwise, definitely after the failure of first line.
Okay. Dr. Mohit, finances
I
are not
think
an issue?
I think even if I do the NGS on the first line, it is hardly change my decision. Maybe I would like to incline to add HER2/neu-based therapy along with the CISGEM, but apart from that, it is, I think, the more useful in the second line.
So why not to do it and keep it for the later
Yes,
time?
sir, we
Or
can do
you
it
would
on the
like
first
to
line, but
have
it is difficult to convince because it will hardly change our treatment decision. So it is difficult to convince the patient that anyhow I will going to offer the same thing.
So
So
let's say
that's the question.
So let's say the patient having no financial issue, they agree to your plan and they are ready to do the NGS CGP for 2.5 lakhs and you get a tumor mutation burden of 50.5.
But in the first line, irrespective of the TMB and MSI or PDL1, I would like to add immuno to the chemotherapy in the first line if we are talking about.
So any other takers on this question? Upfront NGS CGP suggestive of tumor mutation burden 50.5.
I think both the trials have not shown a great difference, even if regardless of PDL1 status, the definitive benefit with durvalumab and also pembro was there. So we can go ahead with the addition of immunotherapy if the patient is ready to take it. And yes, if I get a TMB of 50%, I would like to convince the patient to add immunotherapy along with.
So, we have the blanket approval of using TMB high as a surrogate marker, and you can definitely go for immunotherapy. The reason for that is that the tumors which are having high tumor mutation burden, they tend to produce more neoantigens, and more neoantigens can be very well identified with the immune cells once your anti-PD-1 and PD-1 pathways have been blocked. Because of the huge response rates, FDA has given a agnostic approval for a TMB high tumor, and that goes irrespective. So definitely you can counsel the patient, see, because you don't have that kind of approval with the rest of the immunotherapies, but for Keytruda, you can definitely use it. And I have been fortunate enough, and I have seen a good result in my patient. So I have saved chemo for him. Obviously, this did take a good amount of counseling for the patient, but whenever possible, I think the main aim of this discussion is that if we want to find a targetable mutation, then we should act as well. Definitely, the customization of the protocol needs to be there. So
one doubt, sir.
Yeah.
For TMB high, we can also use MSI, MMR. I mean, that can be done on IHC. That also will be a good surrogate, I think.
But that is not giving you a concordance rate of 100%. So it doesn't mean that the patients who are having TMB high are definitely going to having a DMMR status. You can have a patient with MSI being stable and tumor mutation burden being high. So I don't think there is any correlation up till today between the two.
But sir, in the first line, I
Because
think we would
MSI
like
is
to add
MSI
chemotherapy.
is what this is what you do with PCR, and MMR you do with your IHC. So there only you are looking at your 4 proteins, and in PCR you are looking for the 5 loci. Whereas in the TMB, I think it's more of the genomic scarring in the genomic aberrations where they are able to pick up the higher mutation, somatic mutation burden over there. So I'm not the genetist, but to my knowledge, there is no correlation that if a patient is having MSI high, the patient is bound to have a TMB high. You can pretty well have TMB low as well in those cases. Anyways, so
but in the first line, we would not add chemotherapy.
So that is why I'm saying this was an out of the book treatment. I'm not saying to do it. And because you generally, even I was surprised when I saw the report, you are tempted to use. So, and the patient was keen on avoiding the chemo. So I just told them, let us give me 2 cycles. If your stats improve and you started to show improvement, then you can, definitely wait your chemotherapy for the next step as well. So anyway, that's one lucky story. So the discussion I wanted to here highlight another point is the role of the liquid biopsy for the detection of the FGFR mutation. What all mutations we want to look? We want to look at the NTRK, TMB, BRAF, RET, FGFR, IDH, and HER2. So I think the concordance rate of the FGFR with the liquid biopsy is 87%. If you go with the cfDNA versus tissue, and for FGFR, it is less. So because we generally don't have these medicines available yet of today, I think it is just for discussion sake. Whenever these medicines are there, our brain should work in the right direction. What about the targeted therapies for BTCs? So we have chemotherapy, we all know, and immunotherapy. Currently, we have approval of the Durva and Pembro, not yet in India for Pembro, but yeah, we do have an NCCN approval. And we have anti-VEG, FGFR, IDH, BRAF, HER2, and NTRK. So we have so many drugs available. But the problem here being the availability. Dr. Kripa.
Yes, sir. Tell me, sir.
How many patients of metastatic gallbladder cancer have you treated, and you have given, the blanket combination of Gemcis Durva? How has your experience been?
So Gemcis plus Durva, I do offer only to very few, and sometimes I would say no, not very. I mean, till now only one patient I have offered, which is a CGHS patient.
Yeah.
Otherwise, I really don't push them to take Durva.
Okay, your reservations about the Durva molecule being the data, or you are not happy with the data?
I'm really not so convincing with the data, yeah, but definitely yes. Whoever got responded, they have a very good response with Durva, and yeah, but I really don't really push to take Durva, sir, because you see the number OS benefit, 11.5 versus 12.8. If patient is having all the money in the world, yes, definitely yes. But patient is like not so, then I really not push them. Please do take this. This is going to be one of the best regimen. I don't say.
Dr. Akanksha? Money is not an issue. AIMS people have given you full authority to give Gemcis, Durva. Your take?
Yes, definitely. I'll go with all the patients if I get such a scenario.
Okay. And in your realistic world scenario, Gemcis?
Yeah, Gemcis, I think more than 500 I would have given till now. I keep giving Gemcis.
Yeah.
And Durva also one patient I've given.
Okay. And Dr. Garg, how about you?
Durva, I offer, cost is the issue. So, but Gems is definitely.
See, now the PAP has improved. The cost has gone another by 1/3.
Yes. So people have started accepting it. So more inclination, I think, will be towards immunotherapy, because we see as we grow, we see more responses.
And Dr. Mohit, how about you?
At least I counsel all patients for taking immunotherapy, because if you want immunotherapy, then it is the right time to add them. The later line, their effectiveness will be reduced. So that's the reason which I feel. But of course, the cost is the issue. So because of that, many people are declining. So most of them are taking Cesium. I think I have treated one or two patients or so with the triplet, with the addition of the lower.
So, in my experience, I have given this combination in at least 20-25 odd patients. And out of those 25, I am having 4 or 5 patients who are still continuing Durva maintenance. And that patient received their chemo, at least there have been a period of chemo-free period of 4, 5, 6 months. So it's not that it is going to work in every patient, but in order to find those patients, you need to offer it to every patient. And the drug starts to work after 6 months. So you can just see that the separation of the graph starts after 6 months. So by that time, most of these patients, you have already completed your GEMSIS. And that is the point where Durva needs to be continued further in order to get those, 10-20% of the patient where Durva is going to be effective. And definitely, yeah, cost constraints, yes. And the financial issue does remain a limitation. But I think whenever you find a chance, it is better to offer them the combination. And coming on to the subset analysis, which was done later on the Topaz trial, you can just see that the most common mutation here being TP53, followed by CDKN2, then KRAS, SMED, IDH1. And these numbers, and you know that in Topaz trial, mostly the patients were of intrahepatic cholangio, followed by extrahepatic, and only 10-20% of being a gallbladder tumor. Whereas we have rightly discussed in the beginning, it's the other way around. In our practice, 80% are forming the bulk with the gallbladder cancers, and followed by extrahepatic, and then obviously rarely intrahepatic. So yes, there is a limitation, and there is a significant differences in the alterations as well. So you can just see that in the graph is there, and I think you can just see that TP53 mutation being most common in the gallbladder, because even though their number was less, but still, and then followed by KRAS, ARID, and these tumors, though they have their common origin, they do have a different genomic alterations. And this is the point I wanted to highlight in this discussion. How does these genomic alteration impact on overall survival? Well, generally similar OS benefit with Durva versus placebo was observed in patients with either wild type or alter type, except for if you see this ERBB2 amplification. You can just see in the wild type, they have done a little bit better, and in the amplification where it was, altered, so the immunotherapy has not worked that much. So I will be on a lookout for every patient who is going to harbor ERBB2, or the patient is having an HER2 kind of IHC marker. Now this Keynote 966, Dr. Mohit, your thoughts about Keynote 966?
Pembrolizumab is, I think, equally good, as there is no head-to-head comparison between Durva versus Pembro, but the data is, I think, almost the same hazard ratio of 0.8 and 0.83, and irrespective of PDL1, it is working. So
Right.
I think we can
wait
change
for our
either.
DCI approval, and I think we will be okay to convince our patient either to go to the Durva side or either to go with the Durva or a Pembro side. So I think both are equivocal for us at this current juncture, right?
Yes, sir.
Dr. Nitish, your thoughts about
Yes.
these pemigatinib and futibatinib?
I think let's get those drugs first and know what they can do. But definitely, the trials have shown that they work well, and we all know target therapies are wonderful drugs.
So
And
you are convinced with the duration of response or the PFS or the OS in these kind of scenarios?
basically, I am convinced more with the overall responses because we tend to see lesser number of responses as we increase the number of lines of therapy. So in the second or the third line, the responses may be dismal. It may be about 10 to 20% only. And if here we are getting somewhere around 40 to 50%, it makes a huge difference.
Right. Dr. Akanksha, so you have IDH1 mutant patients, and
Okay, sir.
how about
Hypothetically.
anti-IDH1 mutation?
Yes, sir. It will be good to use IDH inhibitors.
So have you
So,
ever used it in any other malignancy up till today?
no, sir, I have not used.
So the problem is those kind of malignancies are so rare. I think it's there in the Merkel cell or something, IDH mutation or some skin
Yes,
cancer.
sir. AML also it's there. AML.
AML also it's there. And I
Yes.
think that's a different drug which we use in AML, or is it the same?
No, same ivosidenib and an acidenib. It depends on whether it's IDH1 mutation or IDH2 mutation. So same drugs, ivosidenib and an acidenib.
So again, it's a costly drug, not available in India, and you can just see by the data, it is 2.7 months of median PFS, and 6-month rate is 32%, 12-month rate is 22%. Again, we need more workup here. And this is the new drug which is being developed, which is for dual IDH1 and 2 inhibitor. Maybe we'll be having this conference after 2 years. This molecule will have a name. And you can just see that the overall response rate with this combination of anti-IDH1, 2 with the GEMs in 13 patients is to the tunes of 46%, which is a big number. So I am keeping my finger crossed because this was just a phase 1 trial to know which kind of dose will suit the patient. So it was presented in ESMO 23. And okay, so Dr. Kripa, HER2 positive breast cancer, HER2 positive biliary tract cancer. Are you convinced with this phase 2 trial of my pathway? The data is right in front of you.
Yeah, sir. I think I'm this is like fine like to use, but still I feel this NHER2 will be the game changer. Just
Yes.
like lung cancer and everything, like this is going to change the game.
So
Tras2, I used it in at least 5 to 6 patients I used. The responses were really good. And it's almost the PFS, what I noted till of the longest is 18 months PFS is there for one patient. Other patient 12 months she did. So it's only single agent Tras2 I used. I think the Tras2 plus Per2, I mean, I'm convinced to use it. But I think game changer will be NHER2 in this pathway, sir.
agreed. Dr. Mohit, have you ever used GEM, CIS, Durva, and FASGO together?
No. All 4 drugs together, no, I have never used.
Now, people are trying customizing their protocols as per HER2. I have seen a wild prescription as well where they have used GEM, CIS along with Durva and HER2 as well. So there are practicing being made to exploit HER2 receptor left, right, and center. So
I think only Delhi and Bombay people can afford the such fancy regimens. The rest of the centers, like it's really not possible.
apparently the prescription came from Singapore. Anyways, so obviously we, oncologists, we tend to hear wild theories and wild, out of the box thinking. So that was quite unique for me. So what they did was they reduced the dose of NHER2 by 100 mg only. And so the patient was getting NHER2 along with Durva and Gemcis. And I was like, I mean, I have never seen, so I was just speechless and I didn't say anything. So, okay. So the problem with this My Pathway trial was that it was a phase 2 trial and it was done in and HER2 era. And that is why the problem here is mostly limited to the disease control rate. So we are not seeing a huge amount of overall response rate. So that is why I think this combination standalone needs some more power to increase these kind of ORR. So I think you can definitely use it with chemo, and this requires some explanation. You need to inform the family regarding that the combination that you are going to use. Okay. So coming on to tucatinib and trastuzumab, again, So here, where you are targeting, extracellularly and intracellularly, it was a phase 2 trial. Dr. Nitish, your thoughts on the current waterfall graph that you are seeing?
Fairly good response. Overall response rates to the tune of 45%, definitely.
So,
But the
this trial,
regimen, I would, yeah.
made me think whenever we are having these patients, why not to target HER2 from over the top and below in order to make sure the upstream and the downstream pathway both gets, down regulated. So this was one of those trial where you are, keen on using the dual combination.
Definitely. I feel the way pertuzumab was also added. So similarly, this has a better edge because of the intracellular and the extracellular way it acts.
Yeah. So obviously, no discussion will end without me discussing Destiny Pan Tumor 2, which included trastuzumab deruxtecan, where we are seeing an overall response rate of 22% with the median PFS of 4.6 and a median OS for 7. The problem here was these patients were mostly locally advanced unresectable metastatic, and they already had a PD after more than one line, and there were multiple patients who had at least progressed after 2 lines. So the problem with Destiny 02 was number one, small sample size. Number second, mostly these patients have already been exhausted or exposed to multiple lines of the treatment. That is why I think by the time they were there for the Enhertu, their body stores have already depleted so much. So I think with this, I will have to quickly come to the end. And so this is where we are standing now. In 2002 something, we had the ABC1 trial, and in 2009, we had ABC2 trial, and followed by that, we have our GEMSIS standard protocol. 10, 20 years, nothing happened. It remained the standard of care. Topaz changed the protocol. We are now keen on adding GEMSIS Durva, but with the catch of the financial toxicity. And now in the past 4-5 years, the left-right approval, the fast-track accelerated approval of the tumor agnostic indications have made us more greedy towards these fancy molecules like larotrectinib and tractinib and dabrafenib, trametinib. So I think whenever given a possibility, we are happy to use these molecules if finances are not an issue. And the emerging molecule is the next one is the MDM2 antagonist, which is bremimadeline. And obviously, this is for the first time when I was preparing the slide. So we just had a discussion. They are running out of names. They're literally running out of names. And it is going to become a lot more difficult for us to remember. Dr. Nitish, your thoughts?
Definitely. I think the numbers they're adding, it will be like LYN or something like that. And difficult to remember all these names. So this MDM2, I could recall there are a couple of names actually with this drug which has been associated with some other name which starts with LI or something like that. So horrible thing, and horrible time is going to come for us also.
Oh, yeah. We need Chavanprash daily,
That is not going to help us remember these names.
What they have done is they have identified this MDM2 mutation, and they are going to give it either with monotherapy or in combination. So in the monotherapy arm, where only 12 patients were enrolled, they were able to achieve 6 in the stable disease and PR in 4. And in the combination, it was given with as a benilimab, which is anti-PD-1 antibody. So the future is very bright for medical oncologists in the numerology and the name training. And obviously, KRAS G12C inhibitor, which is adagrasib, even though I have never used even sotorasib, but I'm learning about adagrasib over here. And this is there only in 1% of the cholangiocarcinoma. And the response rates are not very bad. You can just see the DCR is to the tunes of 91.7%. So the point I want to highlight is you need to go for an upfront NGS in all the patients whenever possible, wherever possible, in order to find these 1% of mutations, in order to offer them these molecules to achieve a 91% of DCR. So I think
This will be in second line, no, sir?
yeah, I mean,
This
At
will
the
be, I
end
think,
of
Not
the
after
day,
many
upfront
lines.
you will definitely get that kind of approval. You have this molecule, you have this mutation, you go and use this molecule, right? Rest of the molecules we do have now.
This will be after many lines, I believe.
Right now, but see, every molecule it has its own journey. They are going to start it with the third line, then boil it down to the second and first. But that is where the future is. Now you can just see how an HER2 is moving up the scale. It's sooner that we are going to see neoadjuvant intent of Enhertu in the breast cancer. It's very near. And just see how much time has been devoted to trastuzumab or pertuzumab being in the first line, being in the neoadjuvant setting. And now this molecule, it is changing the paradigm. So evolution is the only way that we all are going to be updated and keep motivating ourselves regarding the new evolution of the treatment. So yeah, that's it from my side.
Thank you, Dr. Aditya, for this wonderful moderation of this session. So I think now we will be moving to colorectal malignancies, and the session is sponsored by Elchem. So basically, the story of left and right and how do we manage the colorectal malignancies in a panel discussion. And I would like to call upon Madam Dr. Kripa Bajaj for moderating this session. So I'll request her that we will be quick. Please call upon your panelist, madam, and we can
It
start
will be
with the
very
session.
quick. It'll be very quick. It's already 9:40 actually. So
Yes,
I'll be
yes,
really
thank
kind
you.
enough to close the session as soon as possible. So my
Thank you.
panelist, yeah, sir. So I think first panelist is you, Dr. Nitish Garg from Ludhiana. Dr. Priyanshu Chaudhary, are you there? Dr. Priyanshu? Dr. Rajit Ratan? I can see Dr. Rajit Ratan. Dr. Rajit? Dr. Navdeep Singh? Oh my God, no one is there except Nitish sir. No one is there now.
Can you hear me?
Yes. So,
Dr. Rajit, yes.
Present, ma'am.
Oh, I marked preference to you. So where is Dr. Navdeep is not is there, sir? Dr. Navdeep, no.
Dr. Navdeep is not there. Dr. Priyanshu is also there.
Dr.
If you-
Priyanshu? Yeah, I can see him, Dr. Priyanshu. So Dr. Priyanshu, Dr. Nitish, and Dr. Rajit. So with the three of my panelists, I'll start my panel discussion. So can someone share the slides, please? So before entering the this thing, like how many of you do see oligometastatic CRC, like upfront oligometastatic CRC and metachronous oligometastatic CRC? Out of the 100 colorectal cancers, how many patients will have oligometastatic CRC? Dr. Nitish, first question to you.
I think 10% or less.
Sir?
10%, ma'am.
10%. So upfront as well as metachronous, you see only 10% of your cases.
Approximately, yes.
Dr. Priyanshu?
Similarly, probably 10, maybe slightly higher if you include both synchronous and metachronous. 15 to 20 maybe.
Dr. Rajit Ratan?
Ma'am, yeah, somewhere around that ballpark figure of 10, 15.
10 to 15.
Yeah.
Good. Next slide. The case frequency, as usual, 52 years old gentleman with a loss of weight and altered bowel habit. Next slide. So there is a sigmoid colon lesion is there with a multiple hypodense hepatic lesion. This is upfront metastatic CRC. It's not oligometastatic CRC. So colonoscopy, as usual, there is a massive adenocarcinoma is there. Next slide. So after discussion in tumor board, because though there is a multiple metastases are there, because it is patient is an obstruction, patient underwent sigmoidectomy, and HPR came out to be T3, N1B, and M1. So RAS, BRAF, wild type got noted. So in this, I just want to understand how many of you are sending for tumor mutation burden, as well as other panel, except the whatever we regularly use the colon cancer panel. 13 genes are there. So apart from that, what are the genes additionally you included recently after the data popped up?
I think
Dr.
as of
Nitish,
now, I have been
Nitish.
using colon mutation colon mutation panel only, not added on the other mutational assessment along with, not even the TMB.
Sir, are you using liquid as well, or only you are using solid panel right now?
As of now, tissue, and if the tissue is not available, then liquid. And when I'm using a liquid biopsy, then yes, it is the comprehensive profile along with TMB.
So TMB, in addition, you added, apart from the regular panel, what we are using, you added TMB.
If I'm using liquid, madam, it will be a comprehensive. So it will be about 530 genes, 530 genes.
No, I'm asking regarding solid.
Solid, it is only the colon panel.
Okay.
Colon mutation. No TMB.
Okay. No TMB. Okay. Dr. Rajit?
Madam, pretty much the same. I use the standard colon that we've been using, the RAS, BRAF, maybe HER2 and MSI. That's pretty much
Okay.
I do.
Okay, the same one like all of us are using.
Yes.
Okay. Dr. Priyanshu? So how many of your cases will have a RAS-BRAF wild type, and how many of your cases will have a RAS-BRAF mutated type? So it's a left side. I'm talking only about left side right now. So can you please tell me like what's the percentage of wild type and mutated type?
Actually, I mean, my data would not be justifiable because a lot of my patients are not affording these therapies. So we usually don't test for them. And, a lot of my patients can't even afford sometimes bevacizumab. So otherwise, I think so, 30 to 40% in my practice are actually mutated. KRAS or NRAS, mainly BRAF, I've had very few.
Very few. Okay.
Yeah.
So oligometastatic cancer, the reason why I asked, so when you're choosing the regimen, Dr. Nitish Garg, so are you using triplet regimen upfront, or in oligometastatic cancer where we do intend to have a curative intent treatment? How are you doing? Like you're just going ahead with the chemotherapy, or are you ordering for the NGS panel for the patient?
So two schools of thoughts here. If a patient is extremely fit, triplet drug regimen can be well tolerable. If the patient is not very fit, I think doing NGS gives us a better answer to use a target therapy along with the doublet regimen.
So with the introduction of the recent, a lot of data regarding neoadjuvant immunotherapy, are you keen to do MSI at least when you're using neoadjuvant
Yes.
treatment in
So,
oligometastatic?
So instead of a triplet regimen, I usually tend to add a target therapy or an immunotherapy along with chemotherapy if it is positive in a evaluation.
So if patient is having a RAS-BRAF wild type, will you tend to add some EGFR inhibitor? Or
So it
you
is
just don't want, because there is a data where,
it is a left side disease. The responses may be poor, but yes, definitely I would like to add.
you would like to add. Okay.
Yes.
So there is a data that triplet regimen alone versus like a combination of a triplet with other bevacizumab and cetuximab, like a triplet score really well. And although it's a single trial, so yeah, so when the patient is having oligometastatic disease, though BRAF and RAS like it's appears so wild and mutated, we do often use in metastatic CRC. But oligometastatic, there is a data which says that triplet versus triplet plus target at bevacizumab, triplet only scores well. The reason I really don't know, but the single trial is there, like which has showed that data. And also, if there is MSI high is there, my practice is I tend to introduce immunotherapy early because all of us know like immunotherapy is a really blockbuster in CRC. And apart from dostarlimab also, all of us must have seen really good results with the immunotherapy. So, Dr. Priyanshu, will you agree with the statement that in immunotherapy you want to club, like you just don't want the trial says that triplet alone is a better compared to the triplet plus Bev or cetuximab in an oligometastatic CRC?
So if the conversion is the key, I guess folfoxiri plus cetuximab is the treatment of choice for me at least. And I have not combined immunotherapy with chemotherapy for any conversion therapy. So,
Okay,
but
and
the
curative
yeah,
you want to just store that triplet plus cetuxi are like Bev. but you don't want to introduce immunotherapy in the neoadjuvant setting.
Yeah, even not even Bev. Usually, I've used triplet with Cetuxi, and I mean, the issue is tolerating the full dose of Folfixiri actually. So there are a lot of
But for
GI
Folfixiri plus
toxicity.
Cetuxi, the diarrhea will be terrible, I believe.
Yeah, but I've used in young, like 40 years of age, slight modification of chemotherapy dosage, probably. And I've had a couple of conversions and I've had a few failures too. So it all depends upon how well the patient tolerates and, tumor biology too.
Right. Thank you. Next slide. So what influences the tumor treatment in metastatic CRC based on, like all of us know, the patient characteristics really forms a baseline or backbone for the treatment choice. And tumor characteristics, the burden, resectability, the location do matter. And what are the molecular characteristics? Just now we are discussing regarding RAS, BRAF, MSA, HER2, and patient preference. So in this, like I think this MSA high is going already changed quite a bit of almost. It is in the first line single agent approval is there for almost like pembrolizumab and nivolumab, and Nivo second line, but Pembro first line there is a good approval and the outcome is like amazing. Even in the endometrial cancer also, the outcome is like better. I just want to understand in neoadjuvant as well as adjuvant setting, especially in endometrial cancer as well as the colon cancer, when patient is having MSI high, chemotherapy got replaced with immunotherapy, and a lot of trial data is coming up. The basket trials also showing the tremendous response in endometrial cancer as well as colon cancer. So, Dr. Whom should I ask? I think organizers I'll ask. Dr. Nitish Garg, like, what's your take on this? Adjuvant setting, CRC, MSI high. In what's your take regarding the basket trial data is there, like, which is yet to get published, but interim analysis says that it's scoring well over the chemotherapy in the endometrial cancer as well as colon cancer. So, do you think this is going to be the standard of care in the future for adjuvant setting at least?
I think if it is adjuvant, better to keep the immunotherapy for the later line because we know endometrium is going to relapse anytime soon. And depending upon the basket trial, changing the adjuvant, I am not very convinced with the data to change the standard of treatment. Maybe later on, if the responses and the trials have shown that there is a phase 3 or phase 2 data which has shown a good response and the long term benefit, maybe.
Are you
But
not
only thing
convinced
is,
with the rectum data, like where the neoadjuvant
that's what
immunotherapy?
I was coming to. That's what I was coming to, madam. So, if the patient has underwent a biopsy and that biopsy has been tested, it is MSI positive, patient is not willing for surgery or is not fit for surgery, I would directly start with immunotherapy so that he or she, colon or endometrium, can be preserved or taken out from the surgical aspect.
Understood. So in unfit people, like where surgery will not be a part, there you want to offer this. Right.
Right.
Sure. Next slide, please. So efficacy results of, I mean, it's, I think we have only, I think 5 to 10 minutes of time. We'll just wrap up. So with this crystal data, fire data, like right side versus left side, what's your take? Cetuxi Bev, right side patient is having a BRAF wild type and BRAF mutated type. Do you really treat different in right side or you treat everyone same? Dr. Rajit Ratan?
Ma'am, that's an interesting question. For left side, I think I would prefer cetuximab. And for right side, I would prefer to use bevacizumab. But I think that the situation gets complicated when you bring in panitumumab to the whole debate, because that has seen a equally good effect in both left and right hand side. So that remains my sort of conundrum. If given a choice between Bev and Cetuxi, I would prefer Cetuxi in left side and Bev on the right side.
So doublet agent versus triplet agent, left side versus right side. So I would ask Dr. Priyanshu. Priyanshu, doublet versus triplet. So how you want to, in which patients you want to use on left side? In left side, you want to really use triplet or you want to use only doublet? And right side, like what's your take, doublet versus triplet?
We're talking about this Kera Sanders wild and Bira wild.
Yes.
Yeah. So left side definitely, although it's mainly post hoc analysis, but still I prefer a EGFR inhibitor on the left side.
Right.
And for right sides, definitely bevacizumab is the first choice, and later on probably we can use out of in the second or third line even. But and the left side, then again, first cetuxi or panitumumab, and later on you can use bev.
So
That is
what
the
about the
thing.
doublet agent versus triplet agent in left and right?
Doublet mainly.
Okay, doublet only you prefer in the left side, right side?
For conversion, you were talking about?
No, not for conversion. Metastatic, I'm asking for right side.
No, metastatic conversion or doublet. Both.
Okay, so for the right side, like for young fit patients, I'll show the, if I have a time, I'll show that slide. In right side, the recent ESMO, what they presented is that triplet is a better regimen compared to doublet. And left side, not much difference is that the triplet versus doublet. But right side, certainly there is a difference in the triplet versus doublet outcome. So there's a OS benefit is there. There's a significant OS benefit is there when right side if you use the triplet regimen. So in young fit patients, it's like better to use triplet, like only if it's a fit patient. If not, doublet is a fine, like just like left side. Next slide, I show the slides once I go through it. Next slide. Next slide. So deeper trial, H2H of trial of cetuximab plus folfixiri versus bevacizumab. And what's your take in general on this trial, Dr. Nitish Gar? Can you please throw light on this one? For patients, I mean, for people, any people are there who are like students attending this one. So cetuxi versus bevacizumab. So can you like what you understood regarding this trial?
These were all metastatic, unresectable or metastatic?
It's metastatic CRC. It's metastatic CRC. Like there is some resection rate also. It's there. Next slide. Next slide. So sorry.
Okay,
Previous slide.
so
Previous
there
slide.
was
Previous slide. Yeah.
Just go back. So there was possible some unresectable, maybe oligometastatic kind of a disease.
So few oligometastatic is there, but it's a predominant metastatic disease is there.
So as I answered previously, I would prefer adding cetuximab rather than bevacizumab, because we tend to see that even on the right hand side, the responses might still be better with the KRAS or NRAS wild type disease.
Right. So in left side, there is no debate or question that be it a doublet agent or triplet agent, it's always cetuximab which is going to score better. So that's the take from this one. And the conversion rates to resectability in the oligometastatic also, as one of my panelists suggested that it's better to add cetuximab in some patients. But in oligometastatic, other couple of trials are there. One trial showed strongly that when we are using triplet regimen, so better to not add this because the conversion rate, it's see bev versus cetuxi, but other trials, couple of trials, what I mentioned, triplet versus folfoxiri plus cetuximab, and other trial bevacizumab comparison got done. In both trials, in fact, bevacizumab is like showed the worsened outcomes, maybe because of the post-operative mortality and morbidity, or the healing issues what had happened with the bevacizumab. Cetuximab, not much benefit is there when you are using the triplet regimen. Next slide. So we commenced FOLFOX plus cetuximab 6 courses with regression of the hepatic focal lesions. Tumor board consensus was to continue chemotherapy for further tumor regression. So mind this that there's a multiple mets are there, the bilobar metastases are there. I just want to understand if our patient got a complete response in bilobar metastasis, will someone attempt to do surgery when patient is not having any symptoms, or will they tend to continue only systemic therapy? So most of the times patients do come with the question that I just got complete response. Is it really required to continue treatment or will I undergo surgery? Dr. Nitishkar, what do you answer to the patient?
I think I asked them better to continue the maintenance systemic therapy for maybe around 3 to 6 months more. If the response continues,
The response is continuing. The response is continuing from past 2 years.
Yes, so there is no reoccurrence of the disease. Maybe discuss in the MDT and discuss with the surgeon specifically. If a patient is willing for resection, go ahead with the resection.
Right. Okay. So, sir, Dr. Priyanshu, you agree with the same Dr. Nitish is saying? Patient 2 years down the lane, patient is almost in CR. Only the primary is active. Patient is questioning continuously, like, why don't you just remove the tumor, which is in the colon? And what's your answer to the patient? Will you agree with the Dr. Nitish, or will you just continue the systemic treatment? Bilobar multiple meds in CR after 2 years.
Yeah, so there is some data that probably debulking, or I mean, not debulking, but removing the primary or the remaining sites actually increases the chemosensitivity too. And local therapy for hepatic lesions can be done, whether if it is a local ablation, radiofrequency ablation, or microwave, or surgery, that we have to discuss. And but for a continued response, I would still prefer some local therapy for the primary as well as the
Understood.
oligometastatic setting.
Understood. It's well taken. Well taken. Next slide. So completed 13 cycles, favorable response. There is significant toxicities I just showed. There is a grade 2 toxicities. Next slide. So hepatic metastaectomy got done. It's a bilobar metastasis, but still ablation got done. So do anyone heard regarding histotrypsy, which got recently published from USA? Histotrypsy. Dr. Nitish Garg, like you are the person who is organizing this. I should ask you this question.
I have not heard about it.
So histotrypsy is a one like where it's just many liver mets also can be cured. Like the single lesion, the almost outcome is equal to 95 to 100%. So what we are using is the cryoablation RFA compared to the histotrypsy is a quite advanced one. Even HCC they tried just like RFA of the kidney lesion. They did histotrypsy for a HCC of the liver lesion, multiple lesions, and it came out to be a really successful trial. Next slide. I think we should wrap it up. Everyone is leaving. I think it's all at 10. So patient was kept under wait and watch strategy. Next slide. So again, there is a popping up of the lesion spot noted in the liver. So 2019, and just within no time, there is a lot of multiple progressive lesions got detected. Next slide. So second line FOLFIRI plus bevacizumab till progression got done. There is a persistent and residual grade 2 peripheral neuropathy got noted. Next slide. So again, there is a Ryzen CA got noted in December 2020. So FOLFIRI plus bevacizumab. Next slide. So what is the third line you choose usually? So here there are multiple. There is a not oligoprogression, significant progression in the liver lesions. Will anyone attempt this? So ablating few lesions and just to continue that.
I think if they're countable lesions, then we can think of
Only
ablating them.
here, yeah, here only there is a rise in CA. Is there mild progression of the few lesions got noted? Will you ablate it or will you just continue it?
I think better to continue with the same and do a short interval assessment.
Okay. Next slide. Next slide. Dr. Nitish, shall we wrap it up?
Yes,
Because
madam.
it's already 10:05 and
Yes,
I
yes,
think
yes.
kids are throwing a lot of jitters actually.
Yes,
I'm really
definitely.
sorry to interimly
No
stop,
issues.
but still it's 10:05. So last
Yes.
few slides, I'll just go quickly. Next slide.
Sure.
So FOLFIRI, will anyone change from initially the first line is cetuximab and second I changed to bevacizumab. I ablated it and I continued it. After some time there is a progression. Will anyone rechallenge cetuximab again for a patient like whom you previously used? They did well for a couple of years. Dr. Ratan?
Madam, yes, rechallenging the previous regime, at least some of the drugs is what we tend to do in CA colon. We don't have too many injectables to give beyond your MABs and oxali and irinotecan. So we do tend to use one after the other and see how they respond.
So you're comfortable sequencing just like PARP inhibitor, it's okay for you to sequence if patient is like, because we don't have much, so you want to sequence it like you want to reintroduce the other drug, right?
I constantly do that before I finally switch over
Give
to
up.
therapies.
Right. Next slide. So conclusion, anti-EGFR rechallenge could be a tailored strategy for selected patients. Patients with the RAS and BRAF wild-type left-side tumors, not showing molecular mechanisms of resistance to EGFR inhibition, clinical benefit from first-line anti-EGFR, undetectable markers of acquired resistance to anti-EGFR might be optimal candidates for rechallenge. So this is the conclusion. Out of cetuximab and panitumumab, I think Dr. Ratan as well as Dr. Nitish, which is your favorite? And what kind of side effects you do face regularly by using these two drugs? Dr. Ratan, you conclude this with your experience.
I for reasons because panitumumab also works in right-sided tumors, and
That's why I asked you, because you mentioned specifically that right side there is a good data for this, so I'm just asking you. So right side, like so if it is patient is affordable and like really rich, can afford everything, so then in right side you're okay to offer panitumumab.
yeah.
Okay. What kind of side effects you do see with panitumumab usually, apart from hypomagnesemia, what we see regularly, like what we read regularly, not see?
Rash is always a problem. Patient sort of the face changes over time. And there are too many things to take care of in terms of rashes over hand. The face needs some touch up. So rash is something I'm really worried about. It's sometimes I have to sort of delay the therapy before everything sort of cools down in terms of that reaction.
Right. So I think with this we conclude. There's a lot of discussion is there regarding triplet therapy further, but still like I think next time we may once again Dr. Nitish will organize some conference for us, and there we can discuss.
Sure thing.
Sir, thank you so much, sir, for this opportunity. I think I just quickly go because my son is throwing a lot of tantrums now. Thank you
No
so
problem.
much.
Thank you.
Thank you, Dr.
Thank you, Rajiv. I think thank you everyone, and thank you team for the wonderful organization. We'll see you tomorrow.
Thank you,